Okay, good day, everybody. My name is Andreas Wicki. I'm an oncologist at the university and the University Hospital here in Zurich. And it is a privilege to welcome you to this Precision-Oncology meeting, which I have the honor to chair together with my colleague, Christian Britschgi. Oncology is moving at an incredible pace these last years, and I guess this is a good reason why we should keep the clinical and the scientific community very close together, because we have a lot to learn from each other. And this is one of the raison d'etre of the Zurich Precision-Oncology Symposium, to give a platform exactly for this exchange. Okay, so I'm looking very much forward to all the talks planned this afternoon, and I will hand over to Christian Britschgi for the introduction of our first speaker.
Thank you very much, Andreas. Hello to everyone. Thank you very much for the audience, for everyone who has already dialed in. It's an honor and great pleasure for me to introduce the first speaker. It's Professor Rafał Dziadziuszko from Gdansk in Poland. He trained in radiotherapy and medical oncology in Gdansk in Poland. Then he moved to Colorado to perform a translational cancer research fellowship there, and afterwards moved back to Gdansk again. He serves as a deputy chair of the department and medical coordinator of the early clinical trials unit, and his main focus is translational and clinical research in lung cancer. He's a world-renowned expert in the field, and we're looking forward very much to your presentation, which is entitled Targeted Therapies in Non-Small Cell Lung Cancer, Implications for Comprehensive Treatment Strategy. Professor Dziadziuszko, I would like to invite you to share the screen, and then the virtual floor is all yours. Thank you very much.
Thank you very much, dear colleagues. It's really an honor for me to be with you today and to discuss what's going on in thoracic malignancies in terms of impact of targeted therapies for the outcomes of patients, but also for thinking how we change the place of targeted drugs in comprehensive treatment strategy of non-small cell lung cancer, predominantly non-squamous carcinomas. I'm involved also in early clinical trials in Gdansk. So I have the privilege of taking the lead on introduction of novel agents in thoracic malignancies. This is my disclosure slide. So years ago, we used to divide non-small cell lung cancer into squamous and non-squamous histologies. Typically, non-squamous comprise of about 60% of patients, whereas depending on geographical variations, squamous cell histologies, this is about 35, sometimes 25% of cases. Within the last decade, we focused down on precise understanding on predictive markers within predominantly non-squamous cell subsets, but also now in squamous cell carcinomas, there are options for patients for targeted therapies and also immunotherapies. Here you see a pie chart that is up to date with those molecular aberrations that now take about 75% of non-squamous histologies, of which many are targetable with various targeted agents, starting with EGFR mutations, ALK fusions about 5%, ROS1 fusion about 1 to 2%, BRAF class 1 to 3 aberrations, V600E is class 1, but also the other classes are important for biology and treatment. NTRK fusions, RET fusions, MET exon 14 skipping mutations are among the other aberrations listed here, for which there are targeted agents that are either registered or very close to registration. With all that, there is also emerging number of targets, of which KRAS, specifically G12C, is of particular importance. This slide was compiled about 3 months ago. It's still obsolete because now sotorasib is registered for the treatment of G12C mutant KRAS positive lung cancer, but also other agents listed here for HER2 mutations, NRG1 fusion, FGFR aberrations, and EGFR exon 20 insertions, which were not targetable just a year ago. Now we see that this is changing very rapidly. So with that, I will just briefly mention some news in targeted field, such as amivantamab, which is anti-EGFR MET bispecific antibody, and which is used in patients with EGFR exon 20 insertions. This is about 5 to 10% of patients with EGFR activating mutations. Also mobocertinib is a TKI that produces PFS of 7 months in those patients who were pretreated with EGFR exon 20 insertion. So something that was unreachable just shortly before, now these patients may enjoy other treatment options. And also in patients who have EGFR resistance, either for gefitinib, erlotinib, afatinib, or osimertinib, there is an option for amivantamab, which is in clinical trial right now in a phase 3 setting. A combination of amivantamab and lazertinib, which is reversible specific mutation-specific T790M mutation-specific inhibitor, or HER3-directed antibody-drug conjugate, patritumab deruxtecan. Now, ALK fusion field has moved tremendously since ALK fusions were discovered in 2007 by the Japanese group of investigators. First of all, when I see an ALK positive patient, I take into perspective a number of patients that I have seen in the past with quite characteristic clinical appearance. These patients frequently have pleural effusions, sometimes pericardial effusions, sometimes as the main presentation. They often have nodal involvement in the mediastinum, but also if you palpate closely, you feel the supraclavicular lymph node being there, often liver mets, and up to 40% at presentation have brain mets. Typically, immunohistochemistry is positive for ALK antibodies in these patients, but a golden standard is NGS, of course. We now have 5 drugs registered: crizotinib, alectinib, brigatinib, lorlatinib, and there is also another one which is not used very frequently, with remarkable progression-free survival of around 3 years in case of alectinib, brigatinib, and lorlatinib. What is very important is that all these drugs are available for ALK, and that we can focus on resistance to previous generation ALK inhibitors to wisely use the next generation, and then still consider chemotherapy for those failing patients. Also importantly, the new generation drugs such as lorlatinib have an excellent brain penetration. The same is for alectinib and brigatinib, which is critical for ALK positive disease. Now, ROS1 targeting. ROS1 is a younger sister of ALK, that's how I call it, because it shares about 70% of homology with ALK. Here we have a number of agents, including crizotinib, with limitation of limited brain penetration, and entrectinib, which is very active and has a very promising progression-free survival. But also lorlatinib works in ROS1 positive patients, and there are 2 other agents that are sometimes used off-label there. HER2 is a hot topic right now. Trastuzumab deruxtecan is a good example of drug that was tested in HER2 overexpressing or HER2 mutated tumors with nice response rates. Not surprisingly, HER2 mutations became better predictive markers for the benefit of this drug. And this is how this field is moving forward with a number of agents. Something that we were not able to target for years, that is discovered in about 3% of non-squamous cell carcinomas of the lung, is RET fusion. RET fusion positives are quite aggressive diseases. Now we have a very selective TKIs for RET, selpercatinib and pralsetinib, both drugs with excellent response rates of approximately 60%. These drugs have a very good median progression-free survival and are now being introduced in the clinic. I would say that the RET fusions are not exclusive for non-small cell lung cancer. They are also present in small percentages of patients with thyroid carcinomas, but also with biliary malignancies. So this is an example of drug categories that also may be considered wider. Interesting MET exon 14 skipping mutations. Here, again, 2 drugs, tepotinib, which was registered just last month in the European Union, and capmatinib, MET exon 14 mutant non-small cell lung cancer, because of the biology of MET, which again makes these patients very special and prone to different problems. These drugs have slightly worse median progression-free survival, but still are an excellent option for patients with these aberrations. Interestingly, biologically, MET exon 14 skipping is not placed in the tyrosine kinase domain. It's placed in the juxtamembrane domain, where it makes the receptor less degradable. And that's why the signal is transduced, and that's why the biology of this skipping mutation is of interest from just from the perspective of how this biology works. These 2 drugs are quite effective, but I also would like to mention that patients with exon 14 MET skipping mutations have again very distinct biology. These patients are usually older. They are sometimes smokers, sometimes never smokers. They have very aggressive, poor poorly differentiated tumors, which tend to be more mesenchymal, which is consistent with MET biology. So this is quite frequently that we find these aberrations in lung carcinosarcomas. So it should be kept in mind also when such an entity is seen in the clinic. And then BRAF V600E mutant non-small cell lung cancer. This biology is very similar to what we observe in melanoma, except that in melanoma, we almost entirely see BRAF mutants in D600 position, whereas in non-small cell lung cancer, we have 3 classes of BRAF aberrations, of which BRAF V600E comprises about 50% of cases. In these cases, dual inhibition of BRAF and MEK with dabrafenib, trametinib usually works with median overall survival of 10 months, which is highly variable from my perspective, and encouraging median overall survival. Similarly to KRAS mutations, BRAF mutations lie in the proliferative pathway of the signal transduction. And these patients, somehow, these mutations, unlike EGFR or ALK mutations, tend to be associated with smoking. So the diverse biology here tells us that these mutations behave differently. Also, when you consider immunotherapies for these patient categories, they are typically more responsive, KRAS mutant and BRAF mutant, than patients with EGFR or ALK aberrations. Interestingly, also, there is a small percentage of BRAF fusions in non-small cell lung cancer, which is poorly described. And I can only tell you that from my perspective, these patients also respond nicely to dabrafenib and trametinib or other combination of BRAF and MEK. A small percentage of patients harbor NTRK fusions. This is quite rare in the lung, about not even 1% of patients. But since this is seen also in other malignancies, such as, for example, mask secretory carcinomas of the salivary glands, but also other organs, it's quite common in pediatric tumors also. Then we have drugs which are registered only for this fusion, independently of tumor type. So this is an example of agnostic registration. Larotrectinib and entrectinib work well here. And finally, the holy grail of targeted therapy, which is KRAS. On this moment, because of KRAS G12C, the cysteine portion of this mutation makes the KRAS mutation vulnerable to novel KRAS inhibitors, of which sotorasib and adagrasib are the most commonly and the most advanced in the clinical development, but also a number of other drugs are in the clinical evaluation in phase 1 to 3 trials, with nice response rates of about 50%, and also progression-free survival, which is very promising. It's of interest also that with this KRAS G12C mutation seems to be vulnerable to KRAS G12C inhibitors depending on other commutations, such as, for example, STK11 or KEAP1, which is also of interest for immunotherapy sensitivity. So this is an example of the situation where in the future we'll probably consider not only a single molecular event, but also other commutations to decide which is the best treatment strategy, provided that these mutations were uncovered at the time that clinical development of the drugs was part of the game. So with that, current treatment of advanced non-squamous cell carcinoma, according to current recommendations, include all these molecular aberrations, which have validated tyrosine kinase inhibitors, typically used in the first-line setting. Maybe with the exception of KRAS, Now KRAS may be used in the second-line therapy, as a second-line therapy, as expanded access protocols, and soon probably in the clinic. Usually we use chemotherapy for later because the chemotherapy is not as effective, but also is more toxic. Now, immunotherapy role depends on the biology of disease, with EGFR or ALK positive disease not so sensitive, with limited data, perhaps with atezolizumab and bevacizumab, but also KRAS positive disease seems to be sensitive to immunotherapies depending on co-occurrence of these other mutations. For patients with no actionable genetic mutations, we still use chemo and chemo-immunotherapy combination in the first-line setting, sometimes chemotherapy alone. And in patients with high PD-L1 expression, we typically used immunotherapy as monotherapy in patients with PD-L1 status over 50% of patients. So to summarize this part, we should know the target in lung cancer, and we should know the biology. The biology dictates everything, tells us what's the biology of the disease, and sends us important implications for treatment options, but also for reasons of and signs of treatment failure. We should also know the target very well, have the knowledge of how these drugs differ from each other and how much more effective they are in a very specific situation. The CNS activity is particularly important because many of these patients will relapse in the brain or will de novo show with brain metastasis. And brain as a control tower is extremely important for everyone because any problems there makes the life of the patients miserable. We should be aware of potential added toxicity in combination treatments. That's why many of these drugs are given sequentially. Also, evaluate and monitor resistance mechanism, which is increasingly part of the precision medicine in our field with liquid biopsies will lead towards that part with current limitation of liquid biopsy of around 70 to 80, sometimes 90% of diagnostic accuracy. It's ever-changing water. Increasing number of oncogenic targets makes the comprehensive NGS panel a must for every patient that is diagnosed with non-small cell lung cancer. These treatment options are increasing every half a year. And the selection of these drugs led to substantial improvement in survival outcomes of our patients. Yesterday, I had a patient who I was treating for 10 years for ALK positive disease. At the time that he started, crizotinib was not yet available. I was able to send the patient to expanded access protocol to my colleagues in the Netherlands. Then a year after, was able to provide the drugs in Poland. And gradually over years, the situation improved so nicely that the patient is now with fully grown children and enjoying the best of life, not being almost ever in the hospital. So with 5 minutes left of my presentation, I would like to focus on implications of this game change, which makes higher and higher proportion of our patients acceptable for targeted therapies, the implications for our comprehensive treatment strategy. I would state in my statement number 1 that there is a need for a comprehensive genomic characterization of the tumor before any treatment, particularly non-squamous cell carcinomas. And I believe that this is not only to offer these patients a better treatment in the future, which may be not so important in operable patients or patients who are candidates for SBRT, for example, but it tells us much more about the biology of the disease, potential pattern of failure, and it gives the treatment implications for the future. Now, what is the use of targeted agents in adjuvant setting? This is my statement number 2. We now have the result of ADAURA trial, which is a phase 3 trial with osimertinib, given post-operatively to patients after surgery plus minus adjuvant chemotherapy according to indications. On the left side, you can see a very provocative progression survival advantage for osimertinib, a huge difference with hazard ratio of 0.17, a dream for every clinical trialist. Now we will see whether that holds for the future, because we think that most of the patients in the active treatment group will, when they stop treatment, they will relapse. But a good reason to give osimertinib as adjuvant treatment is a brain relapse rate, which, as you can see here on the right of the panel, is in favor of osimertinib. These patients simply don't recur in the brain. So this is a good argument to use osimertinib post-operatively once it is available in your country. I guess in Switzerland it is. But it's a good argument for me. And again, if you look back to tamoxifen in adjuvant breast cancer setting, many of you are too young to remember these days, but we had clinical trials for 2 versus 5 years when we established that 5 years better than 2 years. I think this similar game will be played here also, particularly because osimertinib, because of its selectivity, is quite well tolerated. Now, my statement number 3, the optimal use of targeted therapies with local treatments in advanced disease has now to be defined. We have a number of phase 2 trials. Matthias is very active in this field, particularly with SBRT options, and I congratulate him for that. And I'm very eager to also participate in these efforts with an ETOP or other, for example, with Astro projects. So how should we combine local treatments, for example, in oligometastatic disease, with systemic treatments? The experience so far tells us that simply the best outcomes are produced when best local therapies are combined with best systemic therapies, and the knowledge of best systemic therapies is essential for that. And also stereotactic brain radiotherapy for brain mets should be reserved for later when you have an option for brain penetrating targeted agents. And that's because we want to avoid toxicity of stereotactic treatments. This toxicity may not be considered as something very huge. However, with years, if you look at radionecrosis and problems with that, that's something also that should be considered, because many of these drugs will produce responses for years. Now, just to remind every non-radiation oncologist in the room that local consolidation therapy plus systemic therapy is better than systemic therapy in patients with oligometastatic non-small cell lung cancer. This is a trial that was recently updated by Dr. Gomez and colleagues, showing us progression-free survival, but also overall survival advantage, with note that most of patients treated systemically were treated with chemotherapy only. Only a small % of patients with targeted agents. So we expect the outcomes of patients with targeted agents to be much better than that. And also a nice example of penetration to the brain with ALK inhibitors. Here you see a slide with median progression-free survival on the right side, which is closely related to CNS penetration in the first-line trials. Crizo, 11 months, ceritinib, 17 months, alectinib, brigatinib, lorlatinib, 30 months in average. This heavily depends on brain penetration, and the first two agents are suboptimal as of now because of suboptimal brain penetration. A little bit of my personal experience: a patient who had a headache after completing chemoradiation because of locally advanced lung adenocarcinoma. A year after, of course, if you know that she's ALK positive, you'll do brain MRI and you see 4 different brain mets here. Patient is treated with alectinib, 7 years. She, without any stereotactic treatment, she's doing perfectly fine with complete response. This is a patient. With brain mets treated with lorlatinib. Now 3 years out with excellent complete response in the brain. And this is a patient that was treated with crizotinib for ALK positive disease. And you can see a small brain met here. He received stereotactic treatment at the time, especially because he was treated with crizo. We believed that was the right thing to do in 2016. And here you see something that's going on here 2 years later. And there is some brain edema. Radiologists will tell you, oh, this is probably brain progression. Now this patient was surgically treated because of the localization of the disease, and there was a brain necrosis, which we couldn't find based on the best MRIs with spectroscopy and so on. We don't use yet PET imaging for that, which is a matter of active debate and investigations. But I can tell you only that the differentiation between brain necrosis and progression, which may also co-occur, is particularly difficult. So implications number 4, the optimal sequencing of systemic treatments is also a matter of debate. Should it be immunotherapy or immunochemotherapy versus chemotherapy alone versus targeted agents, in which subset of patients and in which order? And then combination or sequential. The general principle applies: use the most effective and least toxic treatment first. But also, every molecularly defined subset has distinct sensitivity to these systemic therapies and possible different toxicities after this or that sequence. For example, giving immunotherapy after targeted agents is typically quite difficult. And that also depends on the type of agent and treatment itself. So with that, I'll stop here with my a postcard from our new medical campus at the Medical University of Gdansk, stating once again, thank you for being able to share with you these data, and I'm eager to take any questions you may have. Thank you.
Thank you very much for this beautiful presentation and beautiful campus, by the way. We indeed have some questions from the chat. One is from Matthias Guckenberger, actually, whom you've mentioned, taking up on your, I think it was the take number 3, right? The combination of systemic therapy with the local therapy. I'm just reading from the chat. We more frequently integrate local treatment into stage 4 NSCLC. Do we need to test safety for all combinations of targeted therapy and local therapy prospectively, or only when the toxicity profile overlaps? I think a very relevant question is given the vast number of drugs that we have available, as you have shown in your presentation.
Yeah, this is an excellent question. I have to say that I am on the prudent side of this. So I want to be really sure that there is non-overlapping toxicity, even if it may seem not to be a problem, especially with radiation, as we know that there are some possible interactions with BRAF inhibitors and radiotherapy, but not with EGFR inhibitors. So at least well-demonstrated series of patients with limited patient numbers tells me a lot. Depending on type of treatment, whether that's radiotherapy with targeted drugs, I usually stop the targeted drug. The ideal would be to have a full washout. It's not always possible because of the fact that you want to stop the drug for as little as possible, but I usually do that at least 3 days before radiotherapy. And combination with other therapies, systemic therapies, well, that has to be tested within phase 1 studies, in fact. We don't need to have a very large studies, but we should do that. And many companies now are testing, for example, KRAS inhibitors with immunotherapy is a hot topic because there is a preclinical background telling us that this combination may be synergistic, but we need to have data. So phase 1 study is absolutely a must here. Now I don't know if it answers your question, Matthias.
Yes, so many thanks, Rafał.
Then,
despite I have to admit, we have a slightly different approach in Zurich. So for example, we hardly ever pause or make a break in the targeted therapies. We continue as is because of the kind of concerns of a disease flare. But there's
I agree with that. But please publish. Even if it's a case, it's very important. Please publish that. I would say a flare, if you stop targeted agents, is a devastating story. And I have seen such situations. Of course, if you stop the drug for 2 weeks, you can expect that. And with old age, after EGFR inhibitors, there were publications when you had no other treatment options that these patients simply had died in substantial proportions because of the disease flare. So anytime I don't have any new targeted agents, I still try to go a little bit beyond progression and plan chemotherapy for the moment that the targeted agent is stopped to avoid flare. I would say that with radiotherapy, especially with stereotactic treatment, I didn't experience flare, but I share this concern of Matthias. But if you have such patients, please publish that. It will be at least level 5 evidence for us to use the drugs together with irradiation. Now, the question on the resistance mechanism to KRAS G12C inhibitors. Now that's a very good question. I have to say I haven't explored this subject very much. So I'm sure there will be many collateral activation mechanisms, such as we typically combine. We typically use KRAS inhibitors alone at the moment, but we can expect that perhaps higher sequencing directly through BRAF may be a mechanism. But it's not a field I can share some good data. I have to go through that. I can only tell you that from the perspective of early clinical development, we now have a number of G12C inhibitors which work very nicely. So this field will rapidly progress. I hope we can now also find drugs for other KRAS inhibitors, G13C, for example, but also some others. And this is also actively ongoing field of research. The good point, the aim of SRS is a necrosis. So it's a therapeutic, not side effect. I agree with that. The only problem is that we have a huge problem of managing necrosis if it's associated with edema, and it has consequences for patients. It's a bit a disease by itself. And of course, radiation oncologist side of me tells me use fractionation wisely. 27 grays in three fractions is much better for those PTVs that are bigger, at least 2 centimeters in 20 millimeters in diameter, sometimes 5 fractions to avoid necrosis. But I can tell you only that at least in the ALK field, when we have patients who live now 5 years out, 10 years out, this is a problem. So once you have the drug that penetrates very well to the brain, such as alectinib and lorlatinib, still you may be tempted by keeping your guns in the pocket for later. That's my approach as of today.
I guess that would also be our approach in Zurich, right, Matthias? Particularly in ALK positive disease, we would wait with radiotherapy and wait for the response of the TKI, because frequently we see near complete remissions. Okay, I think those were the questions and the comments from the chat. Thank you very much to the participants who posted them. And I would like to hand over now to my co-chair, Andreas, again, to introduce the second speaker.
Okay, thank you very much, Christian. So we move to the next topic, and it's a real pleasure to introduce Reinhard Dummer. Reinhard trained in Würzburg and Zurich, and actually he trained as an oncologist, an allergologist, a clinical immunologist, a dermatologist, and a dermatopathologist. Actually, he's a professor of medicine at the University of Zurich, and he's the vice chairman of the Department of Dermatology at the University Hospital of Zurich. But when I think of Reinhard, I don't think in the first place of his positions, but in the first place, I think of the numerous standard defining clinical trials he has run. So he really is a thought leader in the field of melanoma. And I'm very glad you are with us today. And I'm looking forward to your talk, which is entitled Melanoma Therapy, Precision Approaches Are Essential.
Thank you so very much for the kind invitation. It's a pleasure for me to introduce you to the melanoma field. And I think melanoma has experienced a tremendous progress. So this is one of the multi-center trials that we have participated in from the EORTC. And I think it was a very good clinical trial comparing dacarbazine with a dose intensified chemotherapy. And you see here the outcome in around 600 patients. And this was actually our daily experience. I think I included close to 2,000 patients in clinical trials with results like this. But fortunately, this has rapidly changed. And nowadays, we are using targeted therapies and immunotherapies. And this is the long-term outcome in our patient population. And what we see here is that the initial benefits are driven by targeted therapy, but after 1 year approximately, the patients that are initiated on immunotherapy have a prolonged benefit. And therefore nowadays immunotherapies, monotherapies and combination therapies are the first preferred treatment options. So let's see, what did we learn about melanoma? And as we have seen nicely for lung cancer, the genomic revolution has really improved our understanding. And I think there was this Nature publication 2020 where we had a number of very intense sequencing approaches that have contributed to improve our understanding of different cancer types. I think this table here, sorry for the, is a little bit small, but I just give you the essentials. is here focusing on the most common cancer mutations in several cancer types. And for melanoma, the interesting thing is that it is not BRAF, that is the most common one, but the most common one is actually CDKN2A. So this is a very important mutation for the cell cycle control, is the most common one in melanoma, and it's not yet targeted. However, we get a clear insight also in the genetic heterogeneity of melanomas, including mutations in epigenetic important genes such as ARID1, and then also other genes like tumor suppressors like NF1. So I think our insights in the genomic landscape of melanomas has really improved. Melanoma, or most melanomas, are derived from the epidermis, and with this are exposed to a mutagen, which is UVB irradiation, and therefore the tumor mutational burden is a key for melanoma. Unfortunately, we don't know how to target these alterations directly, but these mutations often result in new antigens that are new antigens for immunotherapy, and therefore the overall tumor mutational burden is very important for our patients. But this is not true for all melanomas. So we have now a detailed insight in the melanoma landscape, I have to say. So you see here a consensus paper of various pathologists that have introduced a new classification of melanomas. And you see that there is A and B, and A means these are melanomas associated with chronic sun damage. So these are the melanomas that provide us with the new tumor antigens. And then there is a number of melanomas that is not associated with cumulative solar damage. And I think these two melanoma types, so these two subtypes, need special attention, and understanding the specific melanoma subtype has now to be introduced in the management pathway. I have to explain this a little bit. So on the right-hand side, you see amelanotic melanoma from one of our patients. And actually, this patient has very much sun-damaged skin. So we can say this is really a melanoma with a high mutational burden. And on the other side, you see a melanoma of the nail apparatus. And here we know that these melanoma do present a completely different molecular biology. There is actually hardly any UV-induced mutations in these cases, but we see a lot of translocations, and obviously the therapeutic approach must be tailored to the individual melanoma type. So if we think about the genomic landscapes of melanocytic lesions, we also have to consider benign melanocytic lesions that are associated with the melanoma subtype. So for example, for NRAS mutated melanomas, these are often associated with large congenital nevi, or melanomas deriving from the ocular melanocytes, or from the molecular biology similar to a nevus blue, which is a melanocytic neoplasm that is originating in the deeper part of the skin. And then there is the variety of spitzoid melanomas. And I would say the spitzoid melanomas are somehow resembling the landscape of mutations and translocations that you see in lung cancer patients. You see on this list a lot of different mutations, including many genes that are very important for you in lung cancer, such as ALK fusions, MET fusions, RET fusions. So this is a special melanocytic tumor pool that has a lot of similarities to lung cancer. So why is this important? So the melanoma with the highest mutational burden is lentigo-malignant melanoma. So these are melanomas deriving in the face. And there was a very nice clinical investigation here published in Nature by an international research group that showed that the response rate in desmoplastic melanomas that have the highest mutational burden is extremely high, even with a monotherapy of PD-1 blockage. So we are here in a response rate with monotherapy with PD-1 above 70%. So this is an impressive result. And nowadays we believe that the elderly population with cutaneous melanomas does not really need combination therapy with ipilimumab and nivolumab, but PD-1 monotherapy is enough. But for other populations, including the young patients that have multiple nevi or have BRAF mutated melanomas, we still think that the combination of nivolumab and ipilimumab is relevant. This patient population typically has by far a lower mutational burden than the melanomas derived from chronic UV exposed skin in the elderly population. So for a younger patient, even if BRAF positive, we would prefer a combined immunotherapy using ipilimumab and nivolumab. And with this, we can have 5-year survival rates above 50%. So why does this immunotherapy work at all? And I think cutaneous malignancies, including melanoma, are a very good example for the immune editing concept that was developed by Schreiber in the last decade. And the important information that we have to understand in this context is that during the development of the malignancies, the immune system has already realized that there are malignant cells around and has reacted, and that there is an interaction between reactive cells and the malignant cells. And this interaction is mainly governed by the presence of gamma interfering that results, for example, in the upregulation of PD-ligand 1 and impacts on the HLA presentation and the presentation of tumor antigens by the tumor cells. So in this situation, anti-PD-1 therapy can be really sufficient to control the disease. However, this is not so easy. And I mentioned tumor mutational burden is responsible for the tumor mutation for cancer antigens and the outcome of immunotherapy, but it is not enough to predict the outcome of immunotherapies. And this science paper has nicely analyzed cutaneous malignancies, but also a number of other cancer types, including lung, including bladder cancer. And the result was somehow very similar for different cancer types. So obviously here I show you the outcome of this biomarker clinical trial in patients with melanoma. So what was investigated? On one side, the overall total tumor mutational burden was determined. And on the other side, it was analyzed how immunogenic is this tumor. So the authors studied a gene expression profile, what they called T-inflamed gene expression profile. So if you have these two parameters, you have 4 different states. So you have a double positive state, so a very high mutational burden and a very intense inflammatory response. And on the other side, a low one where you have low mutational burden and little immunogenicity, and then 2 intermediate states. And interestingly, using this system, you were able to predict the outcome of immunotherapies with anti-PD-1, with the best results in the inflamed tumors with a high mutational burden. So tumor mutational burden is one important argument, but only in the context of the reaction pattern of the host, we can achieve prognostic factors for immunotherapy and use this in the clinic to decide what type of immunotherapy we should deliver to our patients. And then we have the wide field of targeted therapies. We also already mentioned BRAF, and actually BRAF is for us the most important oncogene. BRAF mutations are present typically in younger patients that have a very high number of benign melanocytic nevi. And actually these benign congenital nevi or acquired nevi present often the same BRAF mutation, so the V600E mutation that is also driving malignant melanoma in the younger population. The mutational pattern for BRAF is very focused on a few regions. So the position 600 is really a hotspot for these mutations. And actually, if we compare this, it's interesting to see that obviously in thyroid and melanoma lesions, this mutation is very present, whereas in other cancer types, it's by far rare. And what we know nowadays is that the differentiations, the neural crest-like stem cell phenotype is a special environment for the outcome of a BRAF mutation. And if you really want to generate the melanoma, you don't only need the specific mutations, but you need the epigenetic programming that you found in neural crest stem cells. And this is demonstrated here with the finding for KRAS versus BRAF. And you see that melanoma and thyroid cancers are mainly the cancer types that carry the BRAF mutations, whereas pancreatic cancer and ampullary cancer and other cancer types are the most commonly affected cancer types by KRAS. And this is due to the chromatin programs that are relevant for the development, in this case, of neural crest stem cells. Obviously, in this context, in this programming, the BRAF mutation is very essential to develop a malignancy. And this is also relevant in the context of specific transcription factors, including the transcription factor ATEP2. And our future developments will be that we try to target the driver mutation, BRAF, together with regulatory molecules that are involved in the epigenetic programming of neural crest stem cells that are, these programs are also activated in melanoma. Well, how is the development of the BRAF-MEK inhibitor combinations? And I think this was an extremely successful development plan. So the data in these programs are extremely consistent. So if you look, for example, here on the progression-free survival hazard ratios in the initial developments for the first two BRAF inhibitors, dabrafenib and trametinib, you see that the results of the clinical trials are more or less identical. So the hazard ratio for dabrafenib versus dacarbazine was 0.37 and 0.38 for the comparison vemurafenib and dacarbazine. And also further developments, so the combination of BRAF and MEK inhibitors has demonstrated that the clinical trials are really very reliable with hazard ratios that are more or less identical. A little bit better than the results for dabrafenib and vemurafenib is the combination encorafenib and binimetinib. Encorafenib is now also used in colon cancer together with EGFR receptor inhibition. I think this is based on the fact that encorafenib might be the better BRAF inhibitor. Actually, the Columbus program has for the first time presented data on a head-to-head comparison of two different BRAF inhibitors, and encorafenib showed a better performance concerning progression-free survival response rate than vemurafenib. As you can see here in this presentation, so this is a 5-year update of the Columbus trial. So this trial has a 3-arm comparison of vemurafenib as the standard of care at the time of trial initiation, versus the BRAF inhibitor monotherapy encorafenib, versus the combination encorafenib and binimetinib. Actually, the monotherapy with the BRAF inhibitor shows very similar long-term results. However, the tolerability of the combination versus the monotherapy is by far better. Therefore, in clinical practice, we are using combination therapies of BRAF inhibitors and MEK inhibitors. So let's come back to the genomic features including tumor mutational burden and inflammatory environment. We mentioned the relevance of these features for immunotherapy. However, this is not specific. So these are data for patients treated with targeted therapy in the adjuvant setting. And again, in the translational program, tumor mutational burden and the T inflammatory signature was analyzed in all the tumor types. And then the outcome of the adjuvant therapy using dabrafenib and trametinib versus placebo was analyzed. And the data are really very interesting. So the best outcome for the adjuvant targeted therapy was achieved if we had a low tumor mutational burden and a high interferon or T-cell inflammatory signature, as you can see in chart number D. And the poorest results were seen in the opposite situation when tumor mutational burden was high, but there was a low interferon signature. And I think this curve, the A curve, is very interesting. So in the A curve, we see that there is an initial disease control on the red curve, and then there is this sharp decrease. And in this, to understand this, you have to realize that the adjuvant treatment has a treatment period of 12 months. So shortly after the discontinuation of the adjuvant treatment, we see the progresses. So this could be a very important signal for the future. We suggested also in this paper that this patient population does not achieve the competence to control the tumor by the immune system, but this targeted therapy is still needed to control it. So in this patient population, based on these progression-free survival curves, you would suggest that the patient is going on for a long-term targeted therapy. So these biomarkers might help us also to determine the treatment duration for individual patients. There is a lot of research ongoing on the mechanisms of resistance to targeted therapy in melanoma, and the data are continuously growing. So I would like to mention this mouse data that have investigated mechanisms of resistance in drug-naive melanomas treated with kinase inhibitors. And what you can see here is that the authors were able, based on single-set techniques, to identify different resistant states. You see here one hyperpigmented state that is dependent on the melanocytic transcription factor, MITF. Then you have an invasive state, so these are completely dedifferentiated cells. And then you have a neural crest stem cell-like state that is contributing to the relapse. So the message here is, so if patients are developing resistance, they have different pools of resistant cells that can contribute to the relapse. And if we want to be more successful with targeted therapy, we have to monitor and analyze the minimal residual disease and then develop treatment approaches to completely eliminate these populations. And in this patient population, it was shown that the retinoid transcription factor RXR gamma is very important for the neural crest stem cell-like type. And by blocking this transcription factor with a RXR antagonist, you can delete this patient population. So I think this will be another approach to individualize treatment approaches in patients during targeted therapy. And then we have one melanoma type that is really a problem for all of us because it is not responding to immunotherapy. It's not a target for kinase inhibitors, which is uveal melanoma. And uveal melanomas, you have seen this, they are related to nevus bleu in the skin, to the blue nevi in the skin. These tumors do not present a lot of mutations, actually very few or even sometimes no mutations. And UV irradiation does not play a role in this patient population. However, obviously there is a completely altered RNA transcriptional profile. And in this profile, we see alterations in the typical drivers of malignancy, however, not on a mutational burden, as you can see on the yellow side, but on the transcriptional RNA level. So it's a completely different biology, not driven by genomic alterations, but by epigenetic changes. So what is interesting on this patient population, that the benign ones, and you know this if you have a blue nevus, and also the melanomas, they always present with a very pronounced pronunciation. So I mentioned amelanotic melanomas. If we come to the melanoma type of the blue melanocytic neoplasms, you never have a loss of pigmentation. So obviously in this context, you might consider the pigmentation machinery as a target for immunointerventions. And unfortunately, there are very few molecules on the surface of cells that can be targeted. Actually, there is one. There is TRP2, tyrosine-related protein, that is also found on the surface. But you can also approach the tumor cells in another way. Intracellular molecules are presented by HLA surface molecules. And if you have a lot of pigmentation genes, you will always have peptides presented by class 1 molecules. And now several companies have initiated to produce recombinant fusion proteins that are recognizing on one side, as you can see here on the right-hand side, that are recognizing peptides associated with HLA, in this context, GP100, a melanocytic differentiation antigen, and these recombinant proteins on the other side have a stimulator for CD3, and with this are similar to bispecific antibodies. They are not antibodies, so it's a recombinant T-cell receptor coupled with a CD3 stimulator. And these molecules have been used to treat patients with uveal melanomas. And fortunately, for the first time, we have now a treatment approach for patients with uveal melanomas that actually have hardly any mutations, that has resulted in an improved overall survival. This molecule, tebentafusp, as you can see here, has an impressive improvement of overall survival in comparison to a control immunotherapy with a hazard ratio of 0.51. So that's quite a strong signal. The things that we do not understand, that these type of treatments hardly induce any objective remissions in these patients. However, we think this is really a promising approach, and these medications are acting as you would predict this. And you can see this on this case of a patient with melanoma. You notice that this patient has obviously extensive vitiligo. So the brown areas are the only areas where you still have normal melanocytes that are carrying GP100. And when the patient gets these types of treatments, then you can induce inflammatory response. You can see the histology on the right-hand side, driven by cytotoxic T cells and CD4 T cells that are really recruited to the direct neighborhood of melanocytes that are strongly producing melanocytic differentiation antigenes such as GP100. And in this context, we think that the pharmacodynamic properties of these treatments can be nicely monitored in the skin. And this can be demonstrated, for example, by gene expression profiles, where we see a very strong induction of inflammatory signals, including chemokines, cytokines, and molecules that are associated with the influx of different T-cell populations. So I think understanding the biology comes first. And for melanoma, I think we have to understand that there are completely different melanoma types, and understanding the specific features on a molecular level, but also on the clinical levels, are key to select the right treatment approaches for these patients. And with this, I really want to stress that we have a lot to do, including clinical trials and biobanking. And with all this information, I think we need a very strong medical bioinformatic department that can support us to manage the data set. And clinical trials are necessary. This is our clinical trial team that obviously is following all the rules for COVID prevention. Thank you very much for your attention.
Thanks a lot, Reinhard, for this brilliant, very interesting talk. I do not see any questions in the chat, so I would ask the participants if there are any questions, please feel free and put them into the chat. But I see somebody raising the hand, so Rafał, please.
Any place for IL-2 still in melanoma, as for non-melanoma guy?
We are working on this. You know that there are new IL-2 preparations like pegylated IL-2. And there is a clinical trial recruited with the combination pegylated IL-2 together with nivolumab. So we wait for this. Actually, the companies are very confident that this, because this combination already moved in the adjuvant setting without having seen the phase 3 clinical trial for metastatic setting. That's brave, but we had some experience with epacadostat, so IDO inhibitors. So I think there's still a place. And the other one is that T-cell transfer. So TIL programs are also showing some promises, at least in checkpoint inhibitor resistant patients, and their IL-2 also contributes to the clinical efficacy.
Thank you.
Okay, second question, Professor Letai.
Hi, I had a question. At one point you were discussing how there seemed to be multiple cell types or cell fates within the same tumor, and the examples you gave was sort of a pigmented state, an invasive state, and a neural crest stem cell state. Yeah. So what I'm wondering is, do you know, or is there any understanding the extent to which these states are fixed, or alternatively, is there simply sort of stochastic flickering between these different states, so that a cell in one state might epigenetically flicker into a cell of another state and flicker into a third state?
Yeah, that's very crucial question, and your concern is right. So these states are not fixed. So we have worked. Our group has worked on the invasive states, or the dedifferentiated state, and if you start with these cells, they can switch back into a pigmented cell type. So I think if we want to successfully deal with these transcriptional profiles, then we have to fix the patients. So we wonder what epigenetic modifiers we can use to keep them in the identical differentiation and then hit them, because if we don't fix them, they will just flip in the other stage. So this transcriptional flexibility and plasticity is a big problem. And I think this is true for many cancer types and is probably one of the most important drawbacks for any type of therapy, including immunotherapy and targeted therapies.
Okay, thanks.
Okay, so thanks again. I would love to ask more questions, but we need to do this bilaterally because we are already running 10 minutes late. And this means we need to move to the next presentation, which is by Professor Florian Lordick. Professor Lordick is the director of the University Cancer Center in Leipzig since 2012. And in 2020 was also appointed chair of the Department of Medicine 2 and study dean of the medical faculty. So on the international level, Professor Lordick is the past chairman of the EORTC GI Cancer Tract Working Group, and he's a director of education of the European School for Medical Oncology. Now, again, the most important thing is something else, at least for me, and that's because I'm proud to say that Professor Lordick is the group advisor of the SAKK GI group. So we have many interactions for different trials running in Switzerland in the SAKK network. Now, I'm looking very much forward to your presentation, which is entitled Chances and Challenges, Precision in GI Oncology. So the floor is yours.
Thank you so much, Andreas, and thank you for the friendship and the interaction that we have between your country and my country. And overall, I must say, when I hear the talk from lung cancer and from melanoma, I'm getting very modest concerning our successes, and I see more challenges than successes in GI oncology. But I want to guide you a bit through about my current picture, how far we are with precision in GI oncology. Overall, we have to say that cancer is a big problem. Approximately half of the population in Switzerland and Germany, in these countries, gets the diagnosis of cancer during lifetime. And the problem is increasing from a global perspective as we are getting older and other diseases can be managed more successfully. We are confronted with more cancer. And among the cancer diseases, GI cancers are a very important part. Approximately every fourth cancer which is diagnosed is a GI cancer. Currently, most commonly colorectal, but also stomach cancer, liver cancer, esophagus cancer is quite common. And when we come to mortality, it's even more dramatic. And all these cancers are in the upper field, including also pancreas cancer. And we will see much more pancreas cancer according to all predictions also in the future. And this is currently certainly not the field where we see a lot of chances and a lot of successes for targeted therapies. Quite still limited. Nevertheless, when you go to what ASCO awarded the success of the year 2021, they said that the molecular profiling which drives progress in gastrointestinal cancer was the advance of the year in 2021. This is interesting. And I was thinking about it. Why did they choose that? I was not involved in that discussion. But to a certain degree, it's true that we have seen a lot of progress. BRAF has already been mentioned, of course, by Professor Dummer. And this is also a topic in colorectal cancer. We have the introduction of combined pathway inhibition, combining EGFR and BRAF inhibition, potentially also MEK. But two targets seem to be enough. This was a step forward for this disease. Of course, also the targeting of DNA mismatch repair deficient advanced colorectal cancers, MSI high, also some other GI cancers. We see a lot moving forward in the field of HER2-directed treatment in gastric cancer, in biliary tract cancer, in colorectal cancer. I will get back to that problem also. We see biliary tract cancer as the new non-small cell lung cancer of the GI tract because there are several actionable alterations, mutations, such as IDH1, FGFR2, HER2 amplifications, some mutations, also DNA mismatch repair. So emerging options in this field. And also we have some moderately effective treatment for BRCA-mutated pancreatic cancer. So I will not go into all these details here. I just wanted to give you an overview what has happened, what has led to approval or may lead to approval in the near future in the field of precision medicine. And I want to go into some specific fields. One of my major interests is upper GI cancer, Barrett cancer, gastric cancer. And it's so interesting to look at the carcinogenesis. And this is a paper which I like very much from a former colleague from Munich, now working in GI oncology in Freiburg, Michael Quante. You may know him or have already interaction with him. It's not so far Freiburg from Zurich. And what he described here in the Barrett carcinogenesis, which from a phenotypical viewpoint, we know since long time, you all have learned about these endoscopic challenges, that now we understand more and more the molecular pathway leading to cancer. And what I found especially interesting is that early on you see patches of clonal carcinogenesis, of a clonal initiation, with different mutations that can be oncogenic, but often for a long time, these are controlled by the immune system, probably by the healthy mucosa of this organ. And then at some point, one of the clones starts to be cancerogenic and leads to the carcinogenesis. But many clones in principle are there that could do the same. And I think this is one of the reasons that leads to a very chaotic and complex biology of the cancer that results. And this was described by several groups. This is an important paper here from the Cambridge group around Rebecca Fitzgerald, who leads the Occam network in the UK. And you see something typical here. This is about molecular alterations, such as amplifications. It's not that we have one driver in this disease, like it has been shown so nicely by Rafał for non-small cell lung cancer. Many of these cancers have several alterations with an oncogenic potential at least. Take this patient here, who is characterized by an EGFR amplification, HER2 amplification, but also HER3 is amplified, HER4 is amplified, even MET is amplified. And this is the typical finding in these diseases. And you can imagine how challenging it is, to go back to the title of my lecture, to target such a patient precisely, almost impossible. And this has also been shown for gastric cancer, by the way, including the heterogeneity, that you have only some overlap of gene mutations or gene amplifications when you compare, for instance, the primary tumor and metastasis. And it gets even more complex on the right-hand side of the slide when you add to this the analysis of liquid biopsy. We see this also in our lab. This is something simple experiment. This is which is done in conjunction with Achim Eigner from our pharmacology department. When we inhibit these cancers with specific inhibitors, like for instance here with a c-MET inhibitor in a MET amplified cell line, what we see is that very fast, after a short period of time, there is a counter-regulatory upregulation of other tyrosine kinases, like for instance HER3. It's the same if we silence these cell lines. And this shows you the picture, which makes it difficult also in the clinic. Targeting or hitting one target in esophageal or gastric cancer often does not lead to the wanted therapy success, because there are so many ways to counter upregulate other pathways or other kinases. So this is really the phenomenon of tumor evolution. One clone is treated successfully, for instance, by targeted treatment. Other clones survive and get predominant, which finally leads to treatment resistance. Long described, but still relevant in our times. And this is another work from my group. It's a network that we ran in Germany for several years. We collected patient data and tumor material. And the objective was to learn more about HER2 resistance mechanism. And the best paper we got out of that, at least in my view, a JCO paper from last year, was to simply look at heterogeneity of the target expression, HER2. And this picture here is comparing two typical examples. On the right-hand side, something you do not find so often in gastric cancer, a homogeneous, nice expression of HER2 membranous in all tumor cells. And on the left-hand side, you see more what we typically see in gastric cancer. You see parts of the tumor that overexpress the target. So this is a cancer that we would call HER2 positive. But next to this part of the tumor, there is another part of the tumor, which you see here. I think you can see my red pointer, which is also cancer, but only weakly staining or not staining for HER2. And you can imagine what happens if you hit the target here. You will probably kill or control this part of the tumor, and the other part will continue to grow and will form the resistant clone. So in terms of survival chances after under HER2 targeted treatment with trastuzumab for gastric cancer, we also saw that only if you have a convincing diagnosis of HER2 overexpression done simultaneously by a local and a peripheral pathologist, this was the setting that we looked at, you have a survival advantage of trastuzumab. While in those cases where you have discordant findings, there is no advantage of trastuzumab at all. And this is in about 25% of those patients diagnosed with HER2 positivity in peripheral centers. And going back to optimal thresholds based on overall survival results, we found that what we typically call HER2 positive is probably not the optimal threshold. You need at least 40% of the cancer cells staining positive for HER2 to have a convincing survival advantage, or you need an amplification ratio of 3.0. The usual one we use is 2.0 to get a benefit from trastuzumab. This is not a statement to not use the old thresholds anymore, because they are established. Drug is approved, and we also have novel drugs that hit the target, but it shows you the problem and the challenge that we have of heterogeneity, and that we need a significant part of the tumor positive for the target to have benefit. We see something typical in gastric cancer. It's the disappearance of the target, like it has been shown here in a publication from the Sloan Kettering. There are also new mutations that may occur de novo or selected. That is typically for developing resistance for HER2 targeted treatment. How can we tackle that? I would say we have a chance to tackle that with the stepwise introduction of liquid biopsies. You know this technology, it can report on circulating tumor cells, but also exosomes or cell-free DNA. Most established for treatment monitoring is probably the measurement of cell-free DNA, where we can see mutations, copy number alterations, fusions, DNA methylation. All this is possible in principle. And there are also some nice publications that show that this can be of use in clinical practice, not yet established in the clinical routine, not in gastric cancer at least, different from maybe lung cancer and some applications in colon cancer. But in principle, we can monitor what happens. This is a publication from South Korea for HER2 positive cancer treated here with a HER2 inhibitor, which does not play a role in clinical routine. But the yellow color here shows the disappearance during response of some tumor cell clones, especially those who stained positive for or were positive for HER2 amplification. And then upon progression, the amplification in yellow came up again, but also something new appeared, like for instance here, FGFR2 amplification or CCNE1 amplification. So this shows you exactly what I told you before. It's a heterogeneous disease. Upregulation of alternative pathways is quite common, but this could be helpful in the future to target then as a next step what is upcoming as a resistance mechanism. And here, this is just another example where HER2 is not coming up anymore, but a MET amplification is coming up. Very typical and biologically understandable. Another interesting example of a new chance for more effective treatment in gastric cancer, but also a challenge. It's Claudin 18.2. This is an interesting target now, which is mainly expressed in diffuse type gastric cancer, which is a disease which is difficult to tackle. And there is a therapeutic antibody developed by our famous colleagues from Mainz, by Ugur Sahin and Özlem Türeci. There is also CAR T cells developed against the Claudin 18.2. And the study and the product which is most far advanced is the antibody IMF362 or Solvituximab, directed against the Claudin 18.2 that produced a nice result if combined with chemotherapy versus chemotherapy alone. This is result from a randomized phase 2 first-line study in a target population that was defined by Claudin 18.2 overexpression in at least 40% of the tumor cells. And it took a while to get to publication from the initial presentation of this study at a previous ESCO meeting. And the new part of our publication that we had last year in the Annals of Oncology was, if you go to a population with a weak overexpression of Claudin 18.2 concerning 40 to 69% of the tumor cells, there was no effect of zolbetuximab. It needed at least 70% or more to achieve a nice benefit. So definition of thresholds, like I showed it before for trastuzumab, is also important here for Claudin 18.2. And interestingly here, the company that bought the antibody, Astellas, focused now with the 2 ongoing phase 3 studies on a population defined by a higher threshold of Claudin 18.2 expression. And we all hope, of course, that these studies called GLOW and Spotlight will be positive and will open new opportunities for our patients. A short word on immuno-oncology for GI cancers. I'm starting again here with the upper GI tract. And this is how we currently see the biology of esophageal and gastric cancer subdivided into very different molecular subtypes. Squamous cell cancer is completely different disease, more similar to squamous cell cancer of the head and neck. And we regard this as at least moderately immunogenic when we think about the activity of immune checkpoint inhibitors, which are long approved already for head and neck, but also by latest approvals now available for patients with esophageal squamous cell cancer, both pembrolizumab, but also nivolumab, and by positive opinion published just some days ago also for the combination of nivolumab and ipilimumab. And for adenocarcinoma, we have these different subtypes, the chromosomal unstable, which is similar biologically to what I showed you for Barrett cancer, and then the highly immunogenic subtypes of EBV, Epstein-Barr virus associated, and MSI-high gastric cancer, and another important subtype, genomically stable or silent, which is often associated to diffuse histology. And where we really have a problem is here in these common subtypes and chromosomal unstable and genomically stable to implement immunotherapy, while in MSI-high it works quite nicely and probably also in EBV associated. And there is an ongoing discussion about the role of biomarkers, simply starting with the expression of PD-L1. And as you can see, the US agencies came to a different result in the interpretation of data and in the approval of the respective drugs compared to the European Medical Agency. It's really a crazy situation that the same drugs, based on the same studies, can be used for a broader population in the North American or the FDA-dependent countries compared to the EMA-dependent countries. We had an intensive discussion on that at the ASCO GI meeting just a couple of weeks ago. We also discussed that during your nice post-ASCO GI meeting in Switzerland. Where we have more certainty, a bit more certainty, is for MSI-high subgroups of gastroesophageal junction cancer. This is an interesting subgroup, of course, characterized by DNA mismatch repair. In gastric cancer, it's mostly caused by the epigenetic silencing of MLH1. And this subtype is very different from the other subtypes, characterized by a high mutational burden. We had that already in the talk of Professor Dummer. It's mostly occurring in intestinal type, more in the middle and distal parts of the stomach, equally common in women and men, and more common in the elderly population. And as you can see here from some subgroup analysis of principally negative studies, interestingly, you can see that immune checkpoint inhibitors such as pembrolizumab, or also combination of pembrolizumab and chemotherapy, is much more effective than chemotherapy alone in MSI-high gastric cancers. So we are pretty sure that this is a treatment to go forward in this subgroup of cancers. We also have information from colorectal cancer. You know, the typical pathways how colorectal cancers may occur are either the classical pathway, the adenoma carcinoma sequence described by Bert Vogelstein for the first time, with some common and typical molecular alterations such as APC, KRAS, and P53. But there is also a less commonly used pathway, which ultimately leads to the microsatellite instability genotype of colorectal cancer. This can either be by hereditary pathways, germline mutation, Lynch syndrome, or by the already mentioned hypermethylation phenotype that can lead to silencing of DNA mismatch repair enzymes. And like in gastric cancer, we can also say for colon cancer that MSI-high subtype is a completely different form of cancer associated with high mutational burden by immune infiltrates. It can have BRAF mutations, which are more common in this subtype than in the other subtypes, but there is also MSI-high without BRAF mutations. And importantly, look at the yellow curve. This is stage 4 during chemotherapy. It has a poor prognosis when it comes to advanced stages. It has a better prognosis in localized stages, but in poor treatment results with chemotherapy if it comes to stage 4. And once again, just to show you how different this cancer is, the mutational burden is high. Immune cell infiltrates are very characteristic. Often the pathologists, the experienced GI pathologists, can also tell us, please look at MSI, or they do it directly, because this looks like an inflammatory subtype of colorectal cancer that is suspicious of MSI-high background. At the invasion front, they often describe upregulation of PD-L1, and there is a more intense infiltration with cytotoxic T cells. All this makes this tumor subtype very susceptible to immune therapy, and this has been shown and proven and has changed standards for first-line treatment of MSI-high stage 4 colorectal cancer in the Keynote 177 that was published in the New England Journal of Medicine 2020 with some recent update. And you can see how much more effective immune monotherapy is in this subtype compared to chemotherapy. But the problem is this is a relatively rare subtype, only around 4 or 5% in the metastatic stage. And the majority of colorectal cancers is what we call immunogenically cold tumors. And the big task now is there any possibility to turn cold into hot? And this is one of the still unresolved challenges that we have. A lot of combinations are now being studied, like a combination of tyrosine kinase inhibitors and pembrolizumab, nivolumab, etc. Everything is combined with everything in the hope that tumors can be made more immunogenic, especially in the MSS subtype. I just, for the very last minutes, and I hope I do not use too much time for that, I just show you what I find interesting as new platforms developed also for GI cancers. It's tumor vaccines, it's gene therapy, of course, genetically modified T or NK cells with some first successes, bispecifics, antibody drug conjugates. We have many of them also now under investigation in GI cancers. And maybe one of the most interesting approaches is the development of personalized vaccines. Here we have a nice collaboration with BioNTech, who you know very well, where the objective really is to characterize the tumor on the basis of the RNA sequence, whole exome sequencing, HLA typing can also be part of that to make a prediction of the personal HLA binding peptides. And based on this knowledge, there is a perspective to develop personalized vaccines, which may help to control better for advanced disease, or maybe even more intriguing, to give adjuvant treatment for high risk and resected localized disease. And of course, mRNA vaccines, which we heard so much about during the COVID period, are specifically interesting technology to deliver such vaccines. And also, this is part of the work we are doing in my department under the guidance of Professor Ulrich Hacker and in collaboration with the Hanover group from Hildegard Bühning. Viral vectors, still very experimental, are interesting technologies, not only to target the cancer cells themselves, but also targeting of the microenvironment, of angiogenesis, of components of the immune system becomes an interesting technology with a perspective to be carried from lab to bedside. So that's it. I thank you very much for your interest, and I'm looking forward to take some questions if there is time for it. Thank you.
Thank you very much, Florian. This was a very interesting, fascinating talk. And I think, I was always a little bit frustrated because lung is leading far ahead. But I do have the hope that GI cancers are to follow now. So there's one question from Alex Siebenhühner, and he's asking, will MSI high mismatch repair deficient gastric and GI junction tumors need chemotherapy in the perioperative setting, or should they just be treated by immunotherapy? So,
yeah, this is such an important and interesting question because some retrospective analyses have shown that there is no good benefit from chemotherapy in the perioperative setting. For instance, MAGIC study has been analyzed. Classic study from Korea has been analyzed on that way. Nevertheless, we also see now some newer data which look at, for instance, the FLOT regimen, where we see some responses. So I would say the current knowledge does not allow for a definitive conclusion. And if we need tumor shrinkage to resect patients safely, we do not avoid chemotherapy completely in this MSI subpopulation. We give a regimen like FLOT. We could also discuss about chemoradiation, of course, to downshrink tumors. But probably the value of adjuvant or perioperative chemotherapy is limited. And I clearly see a future here for immunotherapy as well. At the ESCO meeting, we heard the NeoNIPIGA study from the French colleagues who gave a combination of nivolumab, ipilimumab in a population of little less than 30 patients and achieved a complete remission rate after 12 weeks of treatment, approaching 60%. So I think this shows the perspective.
Okay, thank you very much for this very clear answer. There's a second question, and I'm afraid this has to be the last question. This question is about a short comment on the biology of early onset gastric cancer. So if I get this correctly, the question would be, why do we see some very young patients with gastric cancer? Do we know anything about reasons, genetic or environmental, that leads to this phenomenon?
Yeah, indeed, it's a phenomenon. We see more of that also in pancreatic cancer, by the way. And the reasons are unclear. I mean, there is a subpopulation who develops early gastric cancer on genetic grounds, CDH1 mutation, but it's still relatively rare. And this does not explain the whole phenomenon. And we have a consortium together with Latin America, interestingly, where we also target that. It's probably something we really need to understand better, because it may become a serious problem, early onset GI cancers. And I cannot give a clear answer yet what is going on there genetically, not yet.
Okay, thanks again. This was a very insightful talk, so I loved it.
Thank you.
I will move to the next topic, and for this Okay, it's time to go on, and it is now my pleasure to introduce Professor Nicola Aceto for the next talk. Nicola has trained as a PhD at the Friedrich Miescher Institute in Basel. He moved for a postdoc to Harvard Medical School and the Massachusetts General Hospital Cancer Center. Then went back as an assistant professor to ZLF in Basel, and since 2021 he's a professor of molecular oncology at the ETH in Zurich. Now Nicola's passion is circulating tumor cells, and he's published a series of very intriguing papers on the circulating tumor cells. And I'm very happy to say, Nicola, we had the inclusion of the first patients in your new trial in Zurich just 1 week ago or 10 days ago. So I'm very glad that we can move this forward. And now I'm looking forward to your presentation, which is entitled Biology and Vulnerabilities of Circulating Tumor Cells. And the floor is yours, Nicola.
Thank you, Andreas. Thank you very much for the kind introduction. And of course, it's my pleasure to be here with you all today and to share with you some of our data on circulating tumor cells. So I'm going to share my screen now. I hope everything works fine. And if not, please let me know. So these are my disclosures. And this is what I will talk about today. So as you probably all know, cancer cells, independently of where they are located, most of them will tend to be staying in their original location, but very few will decide at some point or be forced at some point to leave the primary tumor, enter the bloodstream, and that's where we call them circulating tumor cells or CTCs. What is not always said about CTCs is that the vast majority of them is destined to die in circulation. And this is due to several factors. It's due to anoikis, for instance, so that the lack of cell adhesions. It's due to shear stress. It's due to the attack of the immune system. But some of these CTCs will survive, and even fewer will be able to successfully see the metastasis at a distant site. And this is really what my lab is interested in. So we're interested in understanding the biology of the metastasis precursor circulating tumor cells. So we want to understand the hierarchy among CTCs. We want to pinpoint those that are important for forming metastases. And based on their biology, we want to identify new therapies to suppress the metastatic spread of cancer. So today I will tell you in approximately 20-25 minutes how we capture circulating tumor cells from the blood of patients and of mouse models, why some years ago we decided to focus specifically on clusters of circulating tumor cells as opposed to individual CTCs. I will mention some of our recent findings on biology, and most importantly, the vulnerabilities of these CTC clusters. And finally, I'll be wrapping up with some data on new models in metastasis research. So CTC capture is quite an interesting topic. The issue here is clearly the dilution of CTCs in peripheral blood. So if you imagine taking a tube of blood from the peripheral circulation of a patient with cancer, and you can even imagine taking blood from the most aggressive cases and really not responding to therapy and so on and so forth. So in 10 ml of blood, there's more than 50 billion red blood cells, 50 million white blood cells, and typically just a handful of circulating tumor cells. So to isolate these cells for many years has been virtually impossible, but recently many technologies have come up. In my lab, we use a size-based antigen-independent technology to capture circulating tumor cells. The way this works is we take blood samples. These are unprocessed blood samples. They are EDTA tubes containing whole blood. And we run this blood through microfluidic cassettes. The blood goes from the inlet through the device and gets out to the outlet. And if you see it from the top, there is some sort of a serpentine here. And the cross-section of this serpentine is a narrowing channel that leaves an opening of exactly 6.5 micrometers. 6.5 micrometers is really a magic number for CTC research. It allows the passage of white blood cells and red blood cells. This is because they have a diameter that is typically smaller than 6.5 micrometers. And even more importantly, that's because they're extremely deformable. So the job of red blood cells and white blood cells is to squeeze through capillaries and through tissues. So they can very easily pass through here, while cancer cells, which are typically bigger in diameter than 6.5 microns, they cannot do that. And so we can enrich for CTCs in an antigen-independent way. This is a video, which again, I hope it's gonna show okay. So we are imaging here from the top of the microfluidic cassette. You can see millions and millions of blood cells as they flow through the device. And we are imaging around now, and there is a particular region which I'm going to point at now. So you can see the darker region here. This is the 6.5 micrometer gap. And you can see white blood cells as they pass through and they end up in here, and this leads them to the waist. But you can also see that there are some cells that got stuck here before they managed to pass through the 6.5 micron gap. And when we change the filter of the microscope, we can confirm that these are cancer cells because they express cancer-associated markers. So when we developed these technologies a few years ago, and this was done initially in Boston at MGH, in Dan Haber's lab, we were expecting to see mostly single circulating tumor cells in the circulation of patients. But from time to time, we could observe clusters like this one. So this is a cluster from a prostate cancer patient. You can see in green PSMA. You can also see that there are some red blood cells associated to this particular cluster. And I will, white blood cells associated to this cluster stained in red in this case. And I will tell you about these cells in a minute. But basically, when we found these clusters in the blood of patients, we really didn't know why they were there. So we had the really basic questions. We didn't know whether they were contributing to metastasis, whether they were completely irrelevant. So what kind of biology did they have? So we didn't know. The first thing we did, and I will go through this very quickly because it has been published a while ago. So we enumerated single CTCs and CTC clusters in patients with progressive breast or prostate cancer at MGH. And we enumerated them over a period of time. And we could see something very clear. We could see that whenever patients with breast cancer, for example, whenever they had clusters consistently over multiple time points, their progression-free survival was going to be very short compared to patients that had only single CTCs or that had clusters very occasionally. In prostate cancer, the association with poor prognosis was even more extreme. So we could monitor these patients for a longer period of time. We could assess overall survival in this case. And as soon as prostate cancer patient would have just one CTC cluster in the bloodstream at any point in time, we knew that the overall survival was going to be very short compared to patients that had only single CTCs. And then we complemented this with a number of mouse experiments, which I will fly through very quickly. So in short, we labeled tumor cells with different color. This way we could distinguish the contribution to metastasis of single CTCs, because obviously they would be of one color or the other, from that of CTC clusters, which were very often multicolor, because we found that they detach from the tumor already as clusters, and so they carry with them multiple tumor subclones. So by doing that and by doing control experiments, we could determine that CTC clusters are approximately 50 times more metastatic than an equal number of individual CTCs. And we were challenging the dogma at that time, because metastasis was thought to occur mostly through epithelial to mesenchymal transition, and mostly through the loss of cell-cell junctions and through single cells that were going out of the tumor, but clearly that was not the case. So then a very talented postdoc in my lab, Sofia Guntela, who now has her own lab at Novartis, she decided to investigate the biology and vulnerabilities of these clusters. And what Sofia did, she set up a very challenging, but very effective at the same time, single cell methylation profiling of single CTCs and CTC clusters isolated at the same time from patients with progressive breast cancer. So in other words, she wanted to understand whether there are changes in epigenetic changes in DNA methylation level when you compare cluster to single CTCs within individual patients. So Sophia did that, and then she found something very fundamental. So she found that in CTC clusters, there are a very well-defined number of regions that are consistently hypomethylated in clusters, so very, very low methylation levels. And the very same regions are very hypermethylated, so very high methylation in single CTCs. So we then looked at these regions in detail. Don't worry, this is a little bit of a busy slide, but basically it shows you that these regions are binding sites for a number of transcription factors. We did that in patients, we did that in xenografts as well, and we could show exactly which binding sites they are. And if you focus on this particular region of the slide, which is the most important, this is the gene ontology of our findings. We could see that most often the regions that are hypomethylated in CTC clusters are the binding sites for OCT4, SOX2, NANOG, as well as other transcription factors that are extremely important for maintaining a stem-like phenotypes. So you must have heard about these transcription factors before. So these are referred to as the Yamanaka transcription factors. They're very important, for instance, for embryonic stem cells and for maintaining embryonic stem cell identity when there is activity of these transcription factors. So that's how clusters metastasize, and that's why they are good at forming metastases. Then Sophia decided to do a very particular drug screen. So she screened all the FDA-approved compounds that we could put our hands on. And she did it in a bit different way from what cancer screenings, drug screenings are usually done. So she didn't look for compounds that kill tumor cells or clusters, but she looked for compounds that don't kill, but that as a side effect have a dissociation or dissolution of these clusters. So this shows you viability on the x-axis, cluster size on the y-axis. The red dot here is the control. So these are CTC clusters from patients happily growing in cultures as clusters. The green one here is the same clusters that have been broken mechanically, dissociated into single cells. So you can see that the viability is the same, but the cluster size is diminished. And all the other dots are all the drugs that we tested. Most of the drugs don't do absolutely anything to clusters, so you can see them here. There are some drugs that reduce cluster size in this region, but they also reduce viability. So we were not interested in those because they were reducing cluster size for the reason that they were killing tumor cells. What we were interested on were the yellow guys here. So these were 39 compounds that could dissociate CTC clusters almost to the level of single cells, but keeping very high viability, above 70%. And it turned out that many of these 39 compounds were actually inhibiting the same target, which is the sodium-potassium ATPase. So we then validated these findings in mouse models. So we took CTCs of patients, we transplanted them in immunodeficient mice. It took approximately 2 weeks until the tumors were palpable, and an additional 4 months until the tumors started to spontaneously generate single CTCs and CTC clusters that would have gone on to form metastases. But at this point in time, we gave daily IP injections of sodium-potassium ATPase inhibitors. We did that for 3 weeks, and then we measured everything what we could measure. And in these mice, primary tumors were not affected by the treatment, so they were growing happily with and without sodium-potassium ATPase inhibition. And this is consistent with our non-tumor killing strategy that we wanted to use. If you look at CTCs, however, you can see that these tumors that are treated with sodium-potassium ATPase inhibitors produce more single CTCs and less CTC clusters. And this is consistent with our dissociation approach. So you dissociate more, so you get more single cells in circulation and less clusters. And this little unbalanced situation had a massive effect when you looked at metastases. So this is in log scale, and you can see that having less clusters and more single cells in circulation leads to literally shutdown of metastases in patient-derived xenografts. I told you before that sometimes these clusters carry along some immune cells, some white blood cells. And a student in my lab, Barbara Sacerba, decided to investigate these white blood cells that travel together with the clusters. And also in this case, we really had no idea about what are they doing there. So we didn't know whether they were white blood cells that wanted to kill the cluster, or whether they were there to help the cluster, or whether they were completely irrelevant. And so Barbara started to take on this project with a lot of energy and talent as well. And what she could show, and she managed to enroll together with clinical collaborators more than 100 patients with progressive breast cancer. She looked specifically for these CTC white blood cell clusters, and she found them. She also looked at 5 different breast cancer mouse models, with looking at all different flavors. So we have some patient-derived xenografts, some classical xenografts with standard cell lines, mouse in mouse transplantations, syngeneic models with the entire and complete immune system, genetically engineered mouse models also with a full immune system. Long story short, Barbara could find the CTC white blood cell clusters pretty much all the time. In patients, they are extremely rare. They represent roughly 3% of the CTCs that you may find in the peripheral circulation. Most of the CTCs there are single. Some are clusters, and very rarely we see these clusters with white blood cells. In other models, they go from being extremely rare, like in this CTC-derived xenografts, 0.2% of the CTCs are CTC white blood cell clusters, to being extremely prominent, like in syngeneic models. We still don't understand what drives this abundance or lack of abundance. So we still don't know what leads to these changes. But what we know very well is that if you look at patients with breast cancer, and this was a cohort that we had in Basel, it's clear that as soon as patients have just one of these CTC white blood cell clusters in the peripheral circulation, the progression time from primary tumor to metastasis is much shorter compared to patients that don't have CTC white blood cell clusters in the circulation. And among those, there are of course patients that have CTCs, but they don't have these CTCs aggregated with the white blood cells. Then what Barbara did, she did RNA sequencing. She dissociated with a robotic micromanipulator. She dissociated these clusters. She did single cell RNA sequencing and asked in the most unbiased possible way what type of white blood cells they are. So in other words, what is their transcriptome looking like? And she compared the transcriptome of these white blood cells that were traveling with the clusters to that of reference white blood cells that we could isolate from the very same patient. You can see the data here. Shortly, most of the times, white blood cells that are associated to CTCs, they have a profile that looks like myeloid cells in patients. And the same is true for mouse models. So she repeated the experiments in mice to gain more confidence, to gain more N number, because these are very rare cells. And then she complemented that with protein stainings. And she could conclude that whenever you see a CTC in association with a white blood cell, 9 out of 10 times this white blood cell is a neutrophil, and 10% of the times it's something else. Then Barbara did the opposite exercise. So she took the CTCs that were traveling with the neutrophils, and she compared the transcriptome profile of these to CTCs that were not traveling with neutrophils. And the results in this case, they were incredibly clear. So when we looked at the RNA sequencing data, we could see that CTCs that travel with neutrophils, they overexpress genes that define a very active cell cycle and DNA replication process. So in other words, whenever CTCs travel together with the white blood cell or with the neutrophil, more specifically, they can proliferate while they circulate. And this is extremely important because it gives them a lot of advantage when they arrive to the metastatic site. Finally, we were asked by the reviewers for this particular paper to test the direct metastatic ability of all the different types of CTCs that we know. And to do that, Barbara had to micromanipulate and to count 100 cancer cells from spontaneously generated CTC neutrophil clusters and inject them in recipient mice 100 cancer cells from clusters, homotypic clusters without neutrophil, and inject them in recipient mice, and 100 single CTCs and inject them in recipient mice. And then she could measure time to metastasis, and she could measure also overall survival of these mice. And it became very clear in all the models that we tested that CTC neutrophil clusters seem really to be the most metastasis competent subpopulation of CTCs, followed by CTC clusters, and then also single CTCs, which do lead to metastasis, but it takes them a very, very long time. So we then realized that we needed to do one step back because there was a major gap in our knowledge. We didn't know how our cluster is formed in the very first place. So why do tumor cells decide at some point to shed and to leave the tumor as a single cell or as a cluster of cells? So this was a big unanswered question in the field. And Cinzia Donato, a student in my lab, she decided to answer this question. So she developed a particular affinity to studying hypoxia. It was not by chance, but it was because Cinzia looked at the RNA sequencing data of the clusters and of the single CTCs that we developed previously, and she could clearly see that there was some signaling going on in clusters specifically that had to do with hypoxia. And so she designed a labeling system. So this is a lentiviral vector that has HRE sequences. As you know, HREs are binding sites for IF1 alpha, and IF1 alpha is the master transcription factor that is stabilized during a prolonged hypoxia in cells. And so basically, whenever IF1 alpha is stabilized and whenever hypoxia is happening, we could observe that directly because the cells would start expressing YFP, so yellow fluorescent protein, and they would literally become yellow. And so this is the control experiment. Cinzia put the cells in hypoxic conditions. You can see that YFP goes up, and then she puts them back in normoxic conditions, so very high levels of oxygen, and then YFP goes down. And then she injected these cells in mice, and I'm going to show you a video in a second. Before I started, I just wanted to anticipate something. So she injected these cells in mice, and then we let the tumors develop. And so these tumors, while they develop, they experience physiological hypoxic levels and for a prolonged enough period of time. And so what we are now doing and what I'm showing you are consecutive slices of the tumor. We are literally walking the tumor from the bottom to the top. Red is hypoxia, yellow, red is normoxia, yellow is hypoxia. And you can appreciate immediately how hypoxic regions are not only in the core of the tumor, but they are clearly much more widespread. And Cinzia did a very nice quantification of many parameters. And it's clear that hypoxia comes from where there are less blood vessels. However, another misconception in the field, and now we are zooming in one of those regions, is that hypoxia is also corresponding to regions that don't have blood vessels. This is actually not true. So hypoxia corresponds to regions that have less blood vessels, but still there are some. You can see a very big blood vessel here next to a hypoxic region in the tumor. And that means that if hypoxic tumor cells decide to intravasate, they can certainly do that because they have accessibility to blood vessels, to functional blood vessels. And of course, the same is true for normoxic tumor regions. You can look here, the tumor is completely normoxic and there are functional blood vessels in proximity. So both hypoxic and normoxic tumor regions have access to the vasculature and they have chances to intravasate and to become circulating tumor cells. And if you look at the 3D version of the tumor, when we mount all the images together, it is clear that hypoxia is not only in the core of the tumor, but is a much more widespread phenomenon. Then Cinzia dissociated these tumors. She processed hypoxic versus normoxic tumor cells for proteomics analysis. She could see something very clear. She could see that hypoxia in the tumor leads to a very dramatic upregulation of cell-cell adhesion molecules. So the cells stick to each other more when there is hypoxia. And this is again consistent with a lot of literature from embryonic stem cells. This has been shown in many years ago from embryonic stem cells. The consequence of that is if you look at CTCs, single CTCs are most of the times very largely normoxic, and CTC clusters is the opposite. They are most of the times hypoxic. And given the very short half-life of CTCs, which stay in circulation literally for seconds or minutes at best, it's clear that hypoxic CTC clusters derive from hypoxic tumor regions, and that hypoxia is a trigger for the generation of CTC clusters. And if you want to read more about this, there's all the data in the paper that shows you how we could demonstrate that hypoxia really is the starting point for generating CTC clusters. This is another transplantation experiment where we are refining further metastatic ability of CTC clusters. We show that if clusters are hypoxic, they are more metastatic than if they are normoxic. And single CTCs, no matter if hypoxic or normoxic, they are just not good at forming metastases. So this is the same cartoon as I showed you before, just a little bit more detailed. The tumors can have hypoxic regions, can have infiltration of neutrophils, and this leads to the formation of highly aggressive and metastatic CTC clusters and CTC neutrophil clusters. Finally, in the last minute, I will show you something we published very recently. So this is a paper from Manuel Scheidman, a PhD student in my lab. Manuel took advantage of these models. So he isolated CTCs from patients from women with breast cancer that had metastasis to very defined sites. For instance, this particular patient had metastasis to bone, liver, lymph nodes, and brain. He isolated CTCs with the technologies that I showed you before, grew them in cultures, and then transplanted them in mice. And the very nice thing about it is that after 5 to 6 months, these tumors spontaneously shed CTCs which homed exactly in the same organs that were characteristic of metastasis of the patient of origin. And this is extremely rare when you use patient-derived xenografts. At least in breast cancer, most of these tend to metastasize to the lungs or to visceral organs. And this is very different from the biology of breast cancers in patients, which as you know, they tend most often to metastasize to the bone. So we were very pleased to see this. So this is one of the first models that is patient-derived and that is capable to metastasize directly to the bone, to the brain, to the liver, and to the lymph node. These are some close-up pictures of various organs thanks to Tim Schroeder at ETH and his fantastic technology. So we can image the entire organ of the mouse. So you can see here an entire femur of the mouse and cytokeratin positive metastasis that develop spontaneously. This is the spine. You can appreciate very large metastases in the spinal cord, individual DTCs at the level of the vertebrae. So this gives us a nice opportunity also to study DTCs. This is more close-up picture of bone metastasis. You can see green tumor cells as they invade through the bone, and in the background there is this characteristic bone structure. And this is the entire brain of the mouse. So this was a lot of stitching going on, computationally speaking. And you can appreciate a very large metastasis, most likely in the cerebellum. You may also, I'm not sure via Zoom this is good enough resolution, but trust me, there's many disseminated tumor cells throughout the brain, which can be studied and their biology can be investigated. And Manuel engineered these CTC-derived cell lines even further. He overexpressed Cas9 and he engineered the genome-wide guide RNA library where he could study in a genome-wide fashion the contribution of each individual gene for the formation of circulating tumor cells and for the formation of metastasis to each of the sites that I mentioned. Of course, this study has limitations. The main limitation is that it's done on one individual model. Of course, one would have to do it on many more models to see whether this holds true, but he could find many genes that may play a role in organ-specific metastasis. So take home is that CTC clusters are precursors of metastasis in breast cancer, that they display hypomethylation of binding sites for OCT4, SOX2, NANOG, as well as other transcription factors that are very important. We identified FDA-approved compounds that can dissociate these clusters and suppress metastases in preclinical models. And now we have clinical studies that have started where patients receive sodium potassium TPase inhibition, and we are looking at CTC clusters over time. We find that neutrophils can bind to CTCs and thereby they can boost their metastatic potential. And finally, that intratumor hypoxia leads to the upregulation of cell-cell junctions and intravasation of CTC clusters with very high metastatic ability. Last but not least, this is the most important slide. These are people in my lab who are doing all the work that I'm telling you about, and I would really like to thank them for their dedication, for their very, very hard work. Our clinical collaborators in Zurich, in Basel Land, and beyond, also abroad, for their willingness to give us clinical samples. And without them, it would really be impossible to do the research that we are doing. So thank you very much for that. Collaborators at ETH, external collaborators, and of course, funding that makes our work possible. Thank you very much.
May I ask, so congratulations to this fantastic presentation. So obviously you are studying different cancer types. Do you think that cancer types have their own, or let's say disease-specific mechanisms of forming metastases that is probably related to their stemness, so melanoma, neural crest, and epithelial, and so on? Or do you think that the circulating tumor cell clusters use identical mechanisms to survive?
Yes, thank you. This is a very nice question. I think the most honest answer that I can give you is I don't know. So what we know so far is that CTC clusters are extremely important in breast cancer and in prostate cancer as well. So this is clear. This is clear from clinical data. It's also clear from mouse experiments. Next generation of experiments is exactly to answer the question you are asking. So we are exploring many different cancer types now. We're looking at colon cancer. We're looking at melanoma, pancreatic cancer, and so on and so forth, to really understand whether clusters also play a role there. There is quite a lot of clinical data in each of these cancer types. As you know, there's many technologies for CTC isolation, one of which is FDA approved, and it has been used to evaluate the prognostic ability of CTCs and of clusters. And there seems to be a lot in common with breast cancer, but we need to validate this perspective.
Okay, thank you very much. I'm sorry, the hospital just dropped out of the net and the telephones had to reboot again, and the computers as well. But so we are back. I saw that Reinhard, you had your hand raised. So this was another question. You're on mute.
So you missed it. I used the opportunity to ask a question, and I get a stimulating answer. So I think there's a lot of research to do, and well, I saw that Mitch is already on the list of cooperators, so hopefully you will also include melanoma patients in this exciting research.
Absolutely.
Okay, we are very grateful you stepped in, Reinhard. Okay, thanks a lot. I'm just checking the chat whether there are more questions in the chat, which I do not see. And in this case, again, thanks a lot, Nicola, for your talk. Very interesting, and I'm looking at
actually, I think there is a question in the chat. Maybe it got wiped out of yours, but if I could read it.
Yeah, please. It's not in my version of the chat. It got probably lost in translation.
It's from Didier Surdez, who asked an interesting question, which is, do neutrophil cells bind CTC clusters in the blood, or is this interaction already present in the tumor? In other words, would cancers with more tumor-infiltrating neutrophils produce more of these neutrophil CTC clusters?
Thank you, Anthony, and for reading the question. Thank you, Didier, also for asking. So the short answer is that we don't think that neutrophils bind CTCs in circulation. We did experiments where we administered CTCs directly in circulation of mice, and we then extracted them immediately after, and there is clearly no binding to neutrophils there. This is quite intuitive. If you think about cancer cells in circulation, there's a lot of shear stress. So rather than attaching to something, there tends to be a lot of detachment. So the interaction with the neutrophils clearly happens at the level of the primary tumor. So there is infiltration of neutrophils in the tumor, there is binding of neutrophils to tumor cells, and then together they detach and they form circulating CTC neutrophil clusters. Whether cancers with more infiltrating neutrophils produce more of these, we checked, and the answer is not really, at least not very directly. I confess we had a small cohort probably to answer this type of question, but there doesn't seem to me to be a very straight correlation with the numbers of infiltrating neutrophils or the frequency of infiltrating neutrophils. I think there's more than that, and we are trying to figure that out.
Okay, so just to be sure, any more in the chat which I don't see? No, okay.
I can see a hand risen though in the chat, or from Filippo Grillo Ruggeri. So unfortunately, the audience cannot speak up, so please write the questions in the chat.
While we're waiting, perhaps just a quick technical question. Your YFP staining, your YFP positive hypoxic cells, this must be a permanent mark, right? Because the half-life of HIF1 alpha when in a normoxic environment is a couple of minutes. So is that the case that the YFP is indelibly turned on once they're in a hypoxic environment?
It's not indelibly turned on. So it goes down if you put the cells back in normoxia, but the half-life of YFP far exceeds the half-life of CTCs.
I see. So
basically, that's why we can conclude that they come from hypoxic regions.
So, but it's interesting. You could actually track. You could use that differential half-life to actually track, sort of like carbon date, the emergence of these CTC clusters from the tumor cell, but just maybe by looking at YFP intensity.
Yeah, we didn't look at intensity actually, not in this way. So I think it's challenging because they have such a short half-life that it's very hard to further refine it into different moments. But that's certainly a good idea. Yeah.
Okay, I still don't see any question in the chat. Christian, do you or somebody else now?
No.
Okay. In this case, thanks again, Nicola. Very interesting talk, and we're looking forward to all further studies you're going to produce. Very interesting to the oncology community. Then let's move to the next speaker, and Christian, I hand over to you again.
Yes, thank you very much, Andreas. I'm going to introduce Dr. Anthony Letai. He received his MD and PhD from the University of Chicago, then the clinical training in internal medicine and hematology and oncology at the Dana-Farber Cancer Institute. He then moved on to do a postdoctoral research training in the laboratory of the late Dr. Stanley Korsmeyer, and has since then focused in his research on apoptosis and on the mechanisms by which cancer cell can evade apoptosis. And today you're going to talk to us about identifying combination therapies with functional precision medicine. And we're looking very much forward to your presentation. Please, and thank you very much for being with us today.
Great, thanks for having me. Can I confirm that my format is correct and you're seeing the right window? Okay, great.
Yes, it's perfect.
Yeah. Before I start, just some disclosures. I'm on the scientific advisory board of several companies, and I do a bit of consulting as well. And I'll be talking about a technology that my employer, Dana-Farber Cancer Institute, holds all the rights to. I'll start by telling you something that you probably already recognize. Even if you saw had no other information than what you've seen today, every tumor is heterogeneous, and that is whether you just define a tumor across a human population histologically, sort of all colorectal cancer. Everyone's colorectal cancer is different from everybody else's, but even within everybody's colorectal cancer, there is an issue of cellular heterogeneity. So I don't see any other way to get around treating heterogeneous tumors than the treatments that we bring to bear must have heterogeneous elements. And I think this can be viewed pessimistically. It's hard to generate combinations, but I think it can also maybe be viewed somewhat optimistically. And I think you can ask yourself, whatever disease you have, this is a survival diagram, and this could be something like where we are right now with pancreatic cancer or advanced gastric cancer, or one of the tumors that doesn't respond well to most of the things that we apply to it. This is actually where we were in the early 1960s with pediatric acute lymphoblastic leukemia, ALL. And this is back when all we had was mercaptopurine and methotrexate to treat these. So it's two agents that had good therapeutic index and were active, but it was still only two agents. What we saw over the subsequent years was a dramatic improvement in survival of this disease. And this improving survival was largely based on the introduction of more and more and more and more active agents, so that the current regimens treating pediatric ALL, with a cure rate now of over 90% in the developed world, we're essentially up to something like 9 different drugs are brought to bear on the pediatric population with ALL over the course of their 2 years of therapy or so to get these great cure rates. So my point is that even if you're right now in a situation where the disease that you're interested in has maybe a 10% cure rate or 10% long-term survival rate, but there's only 1 or 2 drugs being brought to bear at a time, I think we can still have hope, even in a tumor that's heterogeneous with a poor response rate, that if we can identify, maybe in a personalized fashion, sufficient active drugs, we can have an effect and improve long-term survival nonetheless. So a comment on how do we go about assembling these combinations? So if you were to restrict your answer to this to scanning the pages of, say, Cancer Cell or Cancer Discovery, you would answer, well, it must be mechanistic synergy, that we find one drug that does one thing and another drug that does another, and by themselves, neither drug has any effect, but by a detailed molecular understanding of the pathway that drug A affects and drug B affects, we develop this magical thing called mechanistic synergy, where the 2 parts brought together are much more powerful together than they were either separately. Okay, so, but I think it's worth considering. I think that's nice and it's great when it can be observed, but is it really necessary, and does it really drive how the great results that we might have observed already historically in the case of other curative regimens in cancer? And I think it's worth considering, for instance, this regimen called R-CHOP. This is treatment of large cell lymphoma that currently it includes rituximab, Cytoxan, Adriamycin, vincristine, and prednisone, 5 very different agents acting via very different mechanisms. But the cure rate of patients with R-CHOP is probably something like 60%. And I would argue that it may be the best regimen ever in oncology, probably is responsible for the most cures of cancer compared to any other regimen of chemotherapy we've ever given patients. What's very interesting is that the constituents of R-CHOP are really in no way mechanistically synergistic. This has been studied recently, and there's a series of papers by Adam Palmer and Peter Sorger that I think are very interesting, addressing this issue of the synergy or the lack thereof in a lot of the regimens that we use. They studied the constituents of R-CHOP, and you could see these bliss plots that I extracted from one of their papers. And there's essentially no synergy amongst all these drugs. There's no mechanistic interaction between these drugs. What makes R-CHOP a great curative regimen is that you have 5 individual components, each of which works by a very different mechanism, each of which develops resistance by a very different mechanism. So it's very difficult for a cell, say out of the 10 to the 12, 10 to the 13 cells causing the tumor, for any cell to have simultaneous resistance to all 5 elements of this combination. That's how it works. It really doesn't have anything to do with a mechanistic interaction among these. So in generating combinations, what really does matter? Another thing that really matters is tolerability. And I would say that that is largely outside the realm of the laboratory-based investigator like myself to analyze. There are very poor substitutes preclinically to identifying what is a tolerable regimen. I mean, we can learn from previous clinical experiences, but boy, our preclinical models of toxicity aren't that great. And it gets even more complicated when you deal with combinations. So I think tolerability is very, very, very important. It's almost always overlooked by laboratory scientists like me. And it's really up to the clinical investigators to figure that out. I think we need to have combination regimens that hit multiple independent targets. Synergy is great where we see it, but I think we should observe this as a bonus and not a requirement for developing combination regimens. So in order to do the sort of things that I'm talking about, hitting multiple independent targets, we need to simultaneously, for an individual's tumor, be able to find drugs hitting all those targets. So how are we going to hit all those targets? Well, in some case, you might have a tumor that has been studied for a long time, and just existing knowledge, you can take some of the drugs that we already know work. So for instance, in lymphoid diseases, you pretty much always know that some sort of a corticosteroid or vincristine will be of help, and you can incorporate those into your combination regimen. Of course, we've seen over the last 10 to 15 years, the influence in what I would call static precision medicine, that is based on sort of fixed elements of a pre-treatment sample, something like the genomics, the transcriptomics, the histology, maybe the proteomics and metabolomics. All those things might help us find drugs. I will say after 10 to 15 years of purely genomic precision medicine, we should be aware that it all too often falls short. So I think a reliance purely on genomic precision medicine is not going to be consistent with finding widespread and personalized combinations. So I'm going to introduce you what I call functional precision medicine, and it's really a resurrection of a very simple idea. So cancer functional precision medicine is simply the idea that if you want to know if this drug is going to work on this cancer cell, put this drug on this cancer cell and measure something smart, measure something quick, see what happens, and use that to determine whether or not that drug is a good drug for this tumor cell. I'll point out that even this day and age, this is the gold standard for determining the best treatments in microbiology when we're treating patients with bacterial infections like urinary tract infections or sepsis or pneumonia. And I think it's something that we need to consider much, much, much more seriously in cancer medicine, because there really are no theoretical reasons why we shouldn't be using this. It comes down to major logistical considerations, many of which have been conquered in the last 20 years. So I'll call your attention to this sort of this magnifying glass, which represents the see what happens part of my algorithm. And I'll introduce you a little bit to how my laboratory measures what happens after a drug reaches a cancer cell, and how we can use this to sort of rationally design active combination regimens. So I work on the apoptotic pathway. Commitment to cell death at the apoptotic pathway happens at permeabilization of the outer mitochondrial membrane, the mitochondrial membrane permeabilization event, which also goes by MOMP. This is regulated by the BCL2 family of proteins, which is a balance, and there's a balance of pro and anti-apoptotic BCL2 family proteins that regulate cell death in every cell in your body. Some of these pro-apoptotic proteins, the effect of them can be duplicated by their BH3 domains, a domain that's present in all the pro-apoptotic proteins. And what we determined a long time ago is that you could synthesize just these BH3 domains and titrate them in mitochondria and figure out how ready a cell was for apoptosis. It was a way to measure the balance between the pro and anti-apoptotic family members. If you only had to add a little bit of a BH3 peptide to a mitochondrion to cause mitochondrial permeabilization, then you knew that that was a cell that was very primed for apoptosis, very close to the threshold. Whereas if you had to add a lot of the BH3 peptide to cause MOMP, then you knew it was a cell that was relatively unprimed and far from the apoptotic threshold. And these are the types of peptides that we used. There's the promiscuous peptides that I'm going to talk about first. These interact with all of the anti-apoptotic proteins, and as such, give a good measure of the net anti-apoptotic reserve of a cell or of a mitochondrion. There's also the selective ones. These are used like BAD, NOXA, and HRK. What I'm showing you here is a binding chart with the peptides, the BH3 peptides across the top, and the anti-apoptotic proteins on the y-axis. And where there's a red block, that shows a tight interaction. And what you can see is by using NOXA or HRK, you can identify respectively MCL1 dependent or BCL-XL dependent cells, and you can use BAD to identify BCL2 dependent cells. So now that we have active BCL2, BCL-XL, and MCL1 inhibitors in the clinic, that can be useful to identify that class of BH3 mimetic drug that would be most active on the tumor that you're studying. So let me give you some examples for assembling combinations. Now, I talked to you about how if you want to assemble combinations, you may or may not want to study synergy directly. One way to study synergy directly by these methods is to actually treat the cells with combinations ahead of time, so that you're not only looking at the effect of single agents, but you're also looking at the effect of double agents at least. And you're asking, maybe sometimes you'll see a sensitivity to a combination agent that you didn't see to a single agent by itself due to some sort of mechanistic synergy. And that's the strategy we used in the first story I'm going to briefly introduce to you. This was run by Danielle Potter in my laboratory, a postdoctoral fellow who's now working for AstraZeneca over here in the United States. And she worked on the mesothelioma tumor, a lung tumor of very poor prognosis. That's a tumor of the lining of the outside of the lung, as you probably all know. And we were greatly assisted in this investigation by Raf Bueno, who's head of thoracic surgery at Brigham and Women's Hospital. And the way she does her operation is she does something called dynamic BH3 profiling. And that involves taking primary patient samples straight from the patient, dissociating them into a single cell suspension, and putting them on 384 well plates. Now, she's eventually going to do the BH3 profiling to see how primed they are for apoptosis. But before she does that, she treats these with drugs, either as single agents or combinations. And then she's able to ask the question, are there any drug treatments that actually induce enhanced apoptotic priming that push the cells towards the threshold of apoptosis? Because she's working with primary cells that are not established cell lines, she only has a little bit of time to do this. So she has to accomplish all of this in 24 hours, but that's okay. None of these drugs are likely to kill the mesothelioma cells within 24 hours. It usually takes several days for that to happen. But we're not measuring the completion of apoptosis. We're just measuring the initiation of apoptosis. So this strategy is able to be applicable to a variety of different primary tumors, which we've documented over the last several years. I'm just showing you a couple stories of that. So anyway, she has the primary cells, exposes them to drugs, and then uses BH3 profiling to identify what we call delta priming. And that is the difference in apoptotic priming between a drug-treated well and a non-drug treated well. These are the drugs she used in her screens. You can see the long list that I have there. And she treated all of these samples, both in single kit with just single agents, as well as every pairwise combination. So you ended up with over 300 combinations for each of the tumor samples. And then she did this in an adherent cell population. These cells do adhere to plastic plates. So she used automated analysis to look at the mitochondrial permeabilization. When the mitochondria permeabilize, they lose their cytochrome C. And that can be recognized by immunofluorescence, by automated microscopy and a bunch of algorithmic protocols that she set up to recognize cells that had lost their cytochrome C in response to peptides. So what you can see here, if you look down the cytochrome C column, you see cells that are treated just with DMSO. You see cells that are treated with what we call a non-hit, something that had no effect. At the bottom, you see cells that are treated with the drug, so that now when these same cells have their mitochondria exposed to the BIM peptide, one of the BH3 peptides I was telling you about, there's a loss of cytochrome C. So it's sort of like developing the reaction to show you that there is high priming in cells that are treated with that combination. So did our strategy identify pairwise combinations that showed vulnerabilities in primary mesothelioma cells that were not present if we just looked at single agents? And in fact, you can see that. What you see on the y-axis here is we converted everything to a z-score, our delta priming signal to a z-score, that is how far away from the mean the sort of signal that we were getting from our assay was. And you can see if you look at these pairwise combinations we've chosen here, whether they include navitoclax, a BCL-XL inhibitor, S63845, an MCL1 inhibitor, or venetoclax, a selective BCL2 inhibitor, there seems to be more activity in the two-way combinations that we would have missed if we only looked at these drugs individually. So you can see in particular those combinations that involved a BCL-XL inhibitor or an MCL1 inhibitor, and also included these drugs without going into every one of them. They are in general inhibitors of the PI3 kinase or mTOR pathways, and those combinations seem to work particularly good in these primary mesothelioma samples. And each one of these different icons here represents a different patient sample that she tested. So we focused for subsequent in vivo investigation on this one combination, navitoclax, a BCL-XL, BCL2, BCL-W inhibitor, as well as AZD8055, which is a fairly narrow mTORC1 inhibitor. That's form 1. And she performed, working with Keith Ligon at our facility, they developed a mesothelioma PDX model, and then she simply treated it with the different drugs. And you can see that if you look at this mesothelioma PDX, treatment with single agent vehicle, navitoclax, AZD8055, or venetoclax, which is essentially a negative control, there's very little effect on the tumor. But if you treat with a combination, you actually do see pretty good shrinkage of the tumor, and that is reflected in improved survival of the mice being treated. So here's an example of identifying a combination that if we had just looked at the single agents by themselves, we wouldn't have identified it. So there's some mechanistic synergy that we're observing that was only evident when we did these screens in parallel. But that's not the only way to do these screens. Here's a different example. I'm going to show you a contrasting example. And this is using the PYMT MMTV model of breast cancer. It's a genetically engineered mouse model that can be very convenient to use because it grows relatively rapidly. And Patrick and his team that I showed here, Patrick Bola is a very talented instructor in my laboratory. And he developed a screening strategy where he exposed tumors from these mice to a very large 1,600 member bioactive library and looked for the delta priming to identify active agents. And what he found is that you can see, for starters, very quiet baseline if you look at the non-drug treated populations here. When you treat with the drug populations, this is the drug library here, you can see that there's some dots that emerge above the baseline. That's the delta priming that we're looking for. So from those agents, we chose several that we then counter-screened against normal cell equivalents, either foreskin fibroblasts or hepatocytes, and used that to prioritize our in vivo assays. And here's what it looks like when we went back and treated this mouse model with these agents. And we didn't test any of these in combination. We just screened as single agents. And we saw that dasatinib, which is sort of a broad spectrum kinase inhibitor, and 17-DMAG, which is an HSP90 inhibitor, were both hits. And both as single agents gave us good shrinkage of the tumor, or at least it slowed growth of the tumor. But when we combined them, we got almost near total tumor eradication, suggesting here's a case where just taking the very simple method of developing a 2-drug combination, we took 2 agents that work and just put them together in a tolerable way. And we got very good tumor control. The treatments only lasted 14 days, so you can see there's regrowth after we stopped the treatments. Now, some people have already pointed out, and should come to no news to anyone here, immunotherapy is also a very important concern. I want to point out that immune cells don't kill cancer cells by magic or by lysis, as the immunologists like to tell us. Tumor cells are killed by T cells because the T cells do things to interact with the programmed cell death pathways of the tumor cells, either via cell death receptor pathways or via secreting granzymes that are able to, that perforin allows ingress into the tumor cells, and then they interact with the tumor cells' programmed cell death pathways. So just like drugs, they cause induction of programmed cell death signaling. So let's just treat cell-based therapy like a drug and see if we can identify combinations that will accentuate treatment with cell-based therapies. So I'm going to focus just on combining the right BH3 mimetic with a cell-based therapy and see if that accentuates treatment with this cell-based therapy. And it's going to be NK cell-based therapy. This is work done in my laboratory by Aaron Pan. This is completely unpublished story. In this case, we used the selective peptides here, BAD, MS1, or NOXA, and HRK to identify BCL2 dependence, just as we have for many years. Perhaps most notably, a long time ago in CLL, we were able to identify CLL as a BCL2 dependent disease, which was subsequently vindicated in the clinical trials. It resulted eventually in the approval of venetoclax for CLL and later AML as well. So he performed this assay on 2 cell lines, HeLa cells, and with this MS1 signal showed HeLa cells to be an MCL1 dependent cell line, and this AML cell line, HL60 BCL2, that was, as expected, a BCL2 dependent cell based on the signature from the selective peptides that we have here. So our prediction would be then that adding an MCL1 inhibitor to the HeLa cells would accentuate NK-based immunotherapy. And adding a BCL2 inhibitor to the HL60 BCL2 cells would accentuate it, but not vice versa. And that's exactly what Aaron found. He then performed some in vivo assays where he took human NK cells and put them in mice in which tumors had been established. In this one I'm showing you here, this is the HeLa cells that had been established. And you can see that the combination with S63845, the MCL1 inhibitor, but not the other combinations, gave profound shrinkage of the tumors in the case of HeLa. And you can see that the combination with ABT199 did next to nothing. In contrast, when we had the HL60 BCL2 cell line that was BCL2 dependent, the combination with the BCL2 inhibitor ABT199 caused profound shrinkage, whereas the combination with the MCL1 inhibitor did not. And that's also reflected in improved survival, exactly as you see in the tumor volume curves here. So it appears that BH3 profiling is a good, functional, rational way of identifying the right BH3 mimetic, not only to combine with drugs, but also to combine with cell-based immunotherapy, like NK cell therapy. These sorts of functional assays can also be used as combination regimens. That is, you've already established a regimen, you're not trying to discover one, but you want to identify across a population which of the patients are more likely to respond, which aren't, so you don't have to treat futilely patients who aren't going to respond. And we did this with a novel therapy for induction in AML, the combination of lenalidomide with MEC, mitoxantrone etoposide, and cyclophosphamide, cytarabine in AML. And this was a study run by Jacqueline Garcia. What she found was that we could nearly perfectly predict responders to this combination by doing our assay, this dynamic BH3 profiling, and looking for delta priming. Those that were destined to respond had a very high delta priming signal, as we see in red here, and those who were destined not to respond had a very poor delta priming signal. And if you're familiar with the receiver operating curve, which is a good way to evaluate binary predictive biomarkers, we're able to provide almost perfect predictive power for complete remission or not. So I am very enamored of these functional assays and think they have a great future in cancer. And in fact, founded a society that is destined just to study this sort of thing. So the Society for Functional Precision Medicine is an international society. And in fact, some of our most important members are based in Zurich, as it turns out, and in Northern Europe, where there's a very strong focus in functional precision medicine. Our goal is to bring together everyone who cares about this, patients, scientists, clinicians, to speed the day when these functional assays are introduced as relatively standard diagnostics to guide therapy for cancer patients. If you're interested, please visit our website, sfpm.io, or you can certainly contact me directly as shown here. Or if you're going to the ACR, consider joining our meeting on April 9. You can go to our website to learn more about it. If you're interested in this, what can we do for you? We can publicize your findings. We can help with networking. We are providing a functional precision medicine registry that we're accumulating right now so that we can simply list the people who are providing these services to patients, and patients can sort of have some one-stop shopping to figure out where they can go to get these sort of assays done on their tumors to help them choose the better therapies for their tumors. If you're interested, what can you do for us? Join us. Once you join us, get every member of your lab to join. It's free for them. We can have much more impact if we can have a much larger society, and we can bring a larger membership to people. We can have more influence in our lobbying. We can have more influence in our interactions with biotech and pharma as well. Come to our meetings. We have monthly online webinars. We also have this in-person meeting that we're scheduling in New Orleans for anyone who's coming to the ACR. And if you are a member, let us know how we can help you. Please contact me directly, or you can contact the administrator. And our goal really is just to create a rising tide for this field that will raise all ships and hopefully help everyone who wants to do this work do it better and do it faster. So with that, I will halt my remarks. I've tried to acknowledge the people who did the work as I went through, but here you can see a decent segment of my lab, as well as the many, many collaborators that are necessary whenever you're doing these types of assays on a large number of clinical samples. So I'll stop now and I'm happy to take any questions.
Thank you very much for another beautiful presentation and exciting science. And thank you also for disclosing unpublished data with us. We do have a question from the chat. I would like to start with this one. It's from Thorsten Zenz. Dear Tony, thanks for this lovely presentation. Can you comment on the impact of cell of origin on drug response? Have you systematically assessed this?
Okay. Sounds like a big question. I think I understand what you're asking, Thorsten. So we certainly have found that, for instance, if let's just take the BCL2 versus MCL1 versus BCL-XL dependence, that usually tracks very well with the dependence and expression profiles of the cell of origin. That a great example is T cell malignancies. You may or may not know that as T cells go through their development, they actually alter their expression of BCL-XL, BCL2, and actually go back and forth. Well, if you look at the different malignancies that arise that correlate with these different stages of T cell development, you will find that the BCL2 or BCL-XL dependence of the malignancy tracks very well with the BCL2 or BCL-XL dependence of the actual T cell, of the normal T cell counterpart. So yeah, the cell of origin has a huge effect on response. We definitely see class effects and the sort of things that we see just like in clinical treatment of patients, where the cell of origin has an enormous effect on the response of the drugs that we see.
We have a question from Kjetil Tasken, our next speaker.
Yeah, thank you for a wonderful talk, Tony. And as you said, in the Nordic countries, we're great supporters. So functional precision medicine, your work, and the society as well. And I was just wondering, with your cell-based assays, do you see benefit to calculating like a drug sensitivity score area under the curve? And have you sort of seen any benefit in working with any of the sort of softwares that are coming out that can predict synergies from that type of data?
We have not explored using this kind of machine learning or complicated algorithms to look into predicting synergy. So I can't answer that one.
Okay.
We also haven't, so the drug sensitivity scores that I'm aware of, I think it's a very clever idea. It's been employed by people like Philip Staber and others in Austria, what formerly was Allcyte, now Exscientia, where they compare in a given sample the response of a normal cell to the response of the tumor cell in whatever the assay is. And I think that's a very clever idea. We haven't used that. Some of the tumors we have often don't have enough normal cells to compare. So that's a liability of that sort of strategy. We've turned instead to kind of counter screen against normal cell counterparts, but I don't know which way is better. And I think this idea of that sort of drug sensitivity index is an interesting one. And it's one I've thought about more as I've seen some of the success of other people using it.
We have another question from Thorsten. Can you name some drugs or classes of drugs where these functional assays are particularly poor or good for prediction?
Well, I will say this. Taxanes, I don't know, for anyone who does any functional study we do with taxanes are hard to interpret. Taxanes give very funny responses. So I would say that we tend not to focus on, or we'll still study them, but I don't know that we get great predictive information out of studying taxanes. They give very funny dose response curves on cell lines and on almost anything used. So I'd set those apart. Epigenetic agents, I say, are variable. Sometimes we can predict very well. Sometimes the effects of epigenetic agents are so slow that even our relatively rapid assay doesn't reflect it well. But sometimes we can use it to predict in vivo response pretty well. So that's kind of a mixed bag. I'd say it's quite good for the prediction of response of BH3 mimetics, and kinase inhibitors, I think, are good examples of drugs that perform particularly well in these assays. But I really wouldn't rule anything out. Anything that has as its final common endpoint the mitochondrial pathway of apoptosis, it tends to work fairly well in this type of an assay.
Okay, thank you very much. Very interesting discussion also. With this, I think we have to conclude and move on to the last speaker. I will hand over to Andreas again to introduce our last speaker of tonight.
Thanks a lot, Christian. So indeed, we come to the last presentation, last but not least, as we say. The last talk is from Kjetil Tasken. I'm very happy that you're with us to share your experience on building precision oncology programs. You are a professor of medicine at the University of Oslo, a group leader at the Department of Cancer Immunology, and the head and the director of the Institute of Cancer Research. Your talk is entitled A National Precision Cancer Medicine Implementation Initiative, Prototype Learning Ecosystem for Precision Oncology. And I'm very curious to see how you tackle this in Oslo, in Norway, because it's a big discussion in Switzerland, how we should go about that, how to build a central infrastructure for a precision oncology program, how to scale that. Again, the floor is yours.
Sorry, I was muted. Thank you so much for the invitation to speak. I actually offered two different titles. One was a scientific title, and then this was the other one. It's more of an organizational talk, as Andreas said. If you go back 3-4 years in Norway, we had very little precision medicine approaches that were being offered, and very little, even less that was implemented. Pathology departments were offering small gene panel tests, many of them, but that was about the extent of things. And then in Oslo University Hospital, we set up a working group starting January 2019 to see what could we do to facilitate implementation. And we wrote a very short memo, which basically said that there are 3 things that need to happen in Norway. We need to get molecular cancer diagnostics going. We need to attract clinical trials, maybe build a big national trial, and we need to work in parallel with things getting implemented also into the ordinary healthcare system. And then we basically just started working to see if we could make that happen. And I think this is a problem that many publicly funded healthcare systems has had, so that may be the interesting aspect. So the way we went about this was we set up 2 national meetings, one to discuss the diagnostics, it was in June of 2019, and one in January of 2020 to discuss the possibility of organizing a big national clinical trial. To do that and to make something happen on a national arena, one of the things that we did was to invite the whole country to have a meeting in a room with a flat floor for discussion, and to delete participants from Oslo University Hospital with hard-handedly. My boss did that for us to make room for the other people, and proportionally more room maybe. We managed to get buy-in from the oncology, hematology, pathology environments across Norway. And basically what we said was that we need to have a few common priorities. If everybody was going to ask for their own priorities, we wouldn't be able to build a national initiative that would get funded. And for the second meeting, we also put out a white paper just before the oncology forum meeting, Norwegian Oncology Forum meeting in November, to be discussed at the meeting that we invited to in January of that year. Then we worked along 4 lines. One was the bottom-up line. The other one was aligning with the top-down strategies that the health authorities wanted. We had a minister that wanted to implement precision medicine. He'd instructed the regional healthcare systems, and they tried to instruct the hospitals, but going top down didn't work. So the key was to get the bottom up initiative organized and align that with what the authorities wanted. So those were 2 lines so working. Then we did 2 other lines. We did international scoping to see what are the ongoing precision medicine trials that have been successful. We followed the work of genomic medicine to see what's the patient benefit. We found the DRIP trial that reported in September 2019 with a very high inclusion rate and a relatively high patient benefit. And then we started working with the public-private initiative. Could we align with and liaise with industry also for trial participation. Can we build a consortium around that? So I'll cover some of these things. Our work so far, 3 years later, has sort of led to a series of initiatives. It's the INPRED Norway National Infrastructure for Diagnostics. It's the IMPRESS Norway clinical trial, national clinical trial. Now it's also a clinical cancer research center that was funded recently called Matrix. There's a tumor response evaluation initiative using AI for radiologists. We made a project to attract the radiologists. There is projects on statistics research, healthcare research, reimbursement, ethics, etc. In the inside include project cluster, and then there is something called the Connect Public-Private Partnership. And the infrastructure for precision diagnostics in Norway is set up with 6 sites. There are 6 university hospitals in Norway. Norway is a country with a population of about little more than 5 million. And we piloted this at those university hospitals starting at the end of 2019, going on in 2020. We went national with the piloting in January of 2021, and then the infrastructure went into production when the clinical trial started as of April of last year. Aligning with the authorities, we released funding for investments, and we decided to run a big gene panel test. The TSO 500 through Site Oncology 500 was selected, and then there are 2 sites that will run whole genome sequencing, Oslo and Bergen. And it's been about scaling the infrastructure, and we decided to rely on pathology departments also to be able to reach out to other hospitals, because medical genetics, for example, doesn't have enough specialists in Norway to be able to scale to deal with cancer genomics fully. And the aim has been to provide equal access across the country for patients. And some of the argumentation has been that we want, with a uniform healthcare system publicly funded, we want to avoid patients asking for their own samples and buying diagnostics abroad and then going private, and then coming back to the public healthcare system. Then the INPRED infrastructure was also tasked with part of the funding to set up a national molecular tumor board. 2 meetings every week. It's a pre-meeting for diagnosticians led by pathologist Hege Rusnes, and molecular tumor board meeting that delivers to the referring clinician, and that's led by an oncologist. These meetings run on a closed national net for healthcare, and they're video meetings, and they've been very popular. They've been in sort of running for about 10 months now, and there are about 35 to 50 people on the meetings every week, and there's a lot of competence building involved in that as well. The report that goes back to the clinicians look like this. It's a self-developed clinical decision support pipeline that was developed at Oslo University Hospital, and it comes in a way that it is unpacked and can be mirrored at other hospitals. So the other 5 university hospitals are getting it, and it's aligned with the one that the Karolinska Institute has and the one that the Hartwig Foundation in the Netherlands has. As you can see, it reports things like copy number variation, inversions, deletions, tumor mutational burden, mutations, and which mutations are then significant and what variants and unknown significance. This is what gets discussed with the clinicians. Then, as part of the IMPRESS trial, we will also be able to run projects with Foundation Medicine and Illumina on liquid biopsy, and we see that we can also get that into the reporting. Then we built a national clinical trial. It's IMPRESS Norway, that stands for Improving Public Cancer Care by Implementing Precision Medicine in Norway. It's been funded by a national clinical trial program and the Cancer Society and other entities. And the trial is modeled on the DRUP trial that runs in the Netherlands, which is again modeled on the TAPUR trial that runs under ASCO. There's a parallel Canadian trial. And also importantly for us, there were parallel trials and they were starting in the other 3 Nordic countries. So there is a Danish trial, a Finnish trial, and a Swedish trial, ProTarget, FinProve, and Megalith. So we also liaise to sort of set up similar protocols so that we can actually align data. I'll get back to that. The pipeline was run by the INPRED Norway Diagnostic Infrastructure for the IMPRESS trial involves consenting patients. We tried to build a trial as a second version of DRUP that's even better. So we standardized the diagnostics. We said that all the patients that get included will have a TSO 500 big gene panel test, and we consent patients that are screened, meaning that we can also research on the material from the patients that are getting screened but do not get the drug. And then these patients get analyzed, and they can also get the liquid biopsy analysis in one of these collaborative projects with the Foundation One or Illumina, and if you don't get a tumor sample, we can do the liquid biopsy anyway. We get the report and they get discussed in the National Molecular Tumor Board meeting. That can have 3 outcomes. They may refer back to their ordinary clinical path because we cannot find the drug. They can be referred to other trials. And if those other trials are phase 2B or phase 3, the evidence will be better, and that may be a better option for the patient, and that's considered. And if there are not other options, they can get included in the IMPRESS Norway trial. And that trial is a combined umbrella basket trial, meaning that we open cohorts that are defined by the mutation, by the organ-specific diagnosis and the drug. And then the trial follows a Simon 2-stage model of expanding cohorts, meaning that we start with 8 patients. If there's 1 or more that has a response, and the response to evaluation is at 16 weeks. The cohort expands with an additional 16 patients to stage 2 cohort, and if 5 or more has a response, that's cohorts regarded positive. At what stage it can, in discussion with the pharma company that's involved, expand to a stage 3 cohort that can be up to 130 patients. And then, so the trial is for patients with advanced disease. It's a close collaboration with DRUP and other trials that run in Europe, meaning that we do not open cohorts that have been opened elsewhere. We can aggregate data, etc. The entry is by the defined 500 gene panel test. They get evaluated in the National Molecular Tumor Board. We investigate drugs that are on the market. They're FDA or EMA approved, including improved combinations. And we also give data to the Norwegian Cancer Registry. This is the mechanism whereby the data are given, and the Norwegian Cancer Registry is regulated by law, and it's a complete population-wide registry that collects data from every cancer patient in Norway where nobody's lost to follow-up. They're identified by unique social security numbers. And we can get data back out, so we can also have long-term follow-up on patients, and we can get data from parallel populations of patients so that we can build control cohorts by that model. Then the IMPRESS Norway trial runs at all hospitals in Norway that treat cancer patients. That's 17 hospital trusts, and we have 22 sites open. This is a nationwide organization, and at the moment we're also working to see, can we polish this into a complete trial network that can take a lot of other trials, and that seems to be moving nicely forward. It's run by a small group of 4 people and a little bit of a wider trial management committee, and there's a big trial steering committee that's like a general assembly for the trial. And you can see here that the sites are all over Norway, and politically in terms of funding this, because we raised similar amount of funding for this, like for the National Trial Network, about 10 million euro for each, or about 200 million Norwegian kroner total. Politically, it's important that patients all over the country get access. The testing also gets reimbursed, so that it's the TSO 500 test for patients with advanced cancer is reimbursed by the publicly funded healthcare system, and that's regarded as healthcare to screen patients for inclusion in trials. It was important to the Minister of Health that Norwegian patients should not lose out and not get included in trials because we didn't have the molecular diagnostics. So we started in April last year, and by the end of January, we had about 250 patients referred, and about 180 now. We're about 200 evaluated in the National Molecular Tumor Board, and we've opened somewhere in the order of 35 different cohorts and included more than 50 patients in the trial by now. So we have many open cohorts. This is a swimmer's plot for some of the first patients, and you can see some of them are past the 16-week evaluation. And it's clear that we will have positive cohorts, stage 1 cohorts, but this is also spread out over many cohorts because of the model. It's very early days. There's a lot of expectations for this in Norway. And this is from front page of a national newspaper in January. And so there are clear expectations. Then we worked very hard to get drugs into the trial. We met with some 20 companies, and then we went into global processes with each company, application processes. And there are many types of considerations at the global level as to whether the company will come in and want to participate in the Impress Norway trial. Roche was the first company to come on board, and they came in with 8 drugs, and also with a liquid biopsy project with Roche Foundation Medicine Foundation 1. This is from the press release. And then Novartis was the second company to come in, and later we've had Eli Lilly join, and the latest company that's joined is Insight, also with FGF receptor. And then Roche and Novartis are coming in with additional drugs, gray lines here, because we haven't finished the negotiations, and there will be other companies coming in. Then we also have funding, specific funding to run publicly generic compounds where there is public interest, although there's no commercial interest. So we think by the end of the second quarter this year, we will be at 23 drugs. The DRIP trial now has 32 drugs. So obviously, the more drugs in the trial, the better the aggregated algorithm. And then we're doing several rounds of negotiations with different pharmas to get them into the trial. And it's a general protocol, a framework, and then there's a drug-specific amendment for each protocol. We negotiate the inclusion and exclusion criteria and other parameters that also is then designed to fit company interest, and then they decide on the number of treatment slots that will be available in the trial, and they pay, in addition to providing the drug, it's a research-initiated trial, but they pay about 5,000 euro per patient to cover costs. Then we negotiated for all the Nordic countries. I did that, a Dutch Nordic alliance, which means that all the trials, this is from different press releases, the Nordic trials and the Dutch trial, and other trials that may want to join that have similar endpoints, will aggregate data across, because there are so many open cohorts by this model that it'll be good to be able to aggregate data to fill them more effectively. And the DRIP trial has been very interested in that, and they have about 150 open cohorts. So these combinations get very rare, and in order to effectively gather data about efficacy, it's important to work across, and we are suggesting much broader collaborations there. Then the initiative has other research. So there is a package of projects that goes on. There's research on statistics, cost effectiveness, drug reimbursement schemes, ethical challenges, law and legal framework, patient communication, and other things in the package that's now partly funded, not fully funded. Then we worked in parallel to set up a national public-private partnership. We developed a legal framework that will handle conflicts of interest. And that was a working group with some pharmas, Oslo University Hospital, and Oslo Cancer Cluster, which is a cluster organization for public-private also, and they're facilitating this. And basically in the framework, we set up 4 working groups, one that would look at an interface with the diagnostic infrastructure, one that would interface with the trial, one for discussing reimbursement schemes and health economy, and one for discussing the legal framework. And then since it's a publicly funded infrastructure, investigator-initiated trial, these working groups cannot instruct, they can follow, help, and discuss. So industry partners get the front seat to follow this, but we don't compromise on the structure, you could say. This has been very, very popular. And by the time we had negotiated the agreement, we had the sort of signing thing at the end of December 2020, and we had most of these partners signed. Some have joined later, but most of them signed. And so there's 16 pharmas in the public-private partnership, 2 biotech IT companies, all university hospitals in Norway, the Norwegian Institute of Public Health, the Directorate of Health, and the Norwegian Medicines Agency. And we have Oslo Cancer Cluster, Norwegian Cancer Society, and also the Pharma Association for Norway as associated partners. So with building this in Norway, I think what we achieved is we now get harmonized molecular testing. It's still scaling in Norway. We don't have all the testing sites open yet, but we will get equal standards of care. We will get increased access to clinical trials for cancer patients. There is a mechanism of referral for patients with progressive cancer disease, and they will get the diagnostics, or they are getting the diagnostics. It's reimbursed. We have a national molecular tumor board for implementation, and there's a lot of competence building involved in that. It's very popular. Considerable number of cancer patients will have access to one or more lines of treatment with experimental drugs. For expansion cohorts, we also got a decision very recently that we can have drugs reimbursed for patients with the response inside the trial, meaning that Norway introduced a pay-for-performance model inside the trial while we're still generating the evidence. We strengthen translation research. There's a lot of biobanking and research that will go on. It provides structure for benchmarking new diagnostic procedures. There's a lot of competence building, and we also complement the national registers. Doing this, we've had high-level political support. We've aligned with what the authorities wanted. That's been very effective in this case. It's a close cooperation with the National Public Healthcare System. For that reason, we've been able to elicit a lot of funding, and we also then get public reimbursement now for the testing, which will have a population-wide effect in Norway, also very interesting, and also for the trial. The public-private partnership's also been very effective. So I think we moved things in Norway quite a bit over the last 3 years for this reason. Then if you look forward, what we want is we want more companies into the trial to make the aggregated algorithm work better. We think the trial can live much longer than the individual drugs that are in the trial. We can rotate in and out drugs. We want to introduce other diagnostics, protein biomarkers, drug screening, functional precision medicine, like Tony talked about, that are also developing in Norway, and we want to see that this can be put to use. We want to integrate our AI-based approaches to predict drug synergies. We want to move things forward in the lines of treatment, because we all know that we would like to treat patients with the optimal combination of drug before they become resistant to the individual drugs. The trial network, we're polishing and working on the logistics to be able to take other trials, and it's a rapidly moving field. So it's important to stay on there and try to stay at the edge. Then there's a lot of learning involved. It's a learning about how do we do things when we take national lead. And a lot of it's about being inclusive, demonstrating in every aspect that one is generous, and want to share. Then we've been able to structure the field in Norway. I think one important learning is how important the interaction between clinicians, diagnosticians, and researchers are, and that we need all of them to come together in implementation and in the National Molecular Tumor Board. Understanding the two-way needs and positions is important for building a public-private partnership. The health economy and reimbursement mechanisms has been a necessary aspect. There are very high expectations, and then I think this involves things that are very complicated, policy and politics at multiple levels. That's difficult to navigate for medical people like us that are researchers and don't understand all of that, but we've been trying to see how can we navigate it. And I think there are some unique aspects to what we've done in Norway. We have diagnostics with the population effect that will now scale. We're getting reimbursement for early implementation. And we've been able to sort of gather people for a national initiative. So, and this shows some of the people that have been involved in the Impress Norway trial and the IMPRED infrastructure. And with that, I will stop, and I'll be happy to take any questions that may be there.
Okay, thank you very much. So I must say I'm very impressed by what you have shown. I guess that's really an outstanding way how to build a precision oncology program. I've seen more praise in the chat already, which is certainly deserved. Let's move to questions. So Tony Letai, please.
Chato, that was great and very impressive organizationally. And also I'm delighted, of course, that you anticipate including a functional precision medicine component. I think that's really the wave of the future. But one thing, have you considered, or are you already doing, while you're waiting for that, you have an enormous resource in the tumor samples you're collecting for this. And you say you're storing a lot of them, but I'll bet a lot of them aren't being stored viably. It's an incredible resource for functional medicine if some of those samples could, even now before you have a component, that would be an incredibly valuable retrospectively to be able to test viably frozen samples.
So we didn't have funding for that when we started in beginning of last year. We raised funding for what's called the Matrix Center for Clinical Cancer Research now. That's the 128 million fresh kroner that comes from the Norwegian Research Council. And in that, we have funding to go to functional samples. So I think we will go there as soon as we can, basically. Some areas, as you know, CLL, other leukemias, lymphomas, we're storing functional samples. But, you know, if you go beyond that, we don't have them that much, but we want to go there.
Great. Okay.
There's one more question in the chat. I get this is a very interesting one. So in your experience regarding molecular testing, what's the expected real world turnaround time? So from the time point where you include a patient to the report, from the final report from the tumor board?
So at the moment, on average, that takes 5 weeks. That's too long. And looking at those 5 weeks, it's from we run the samples, extract the, assess the samples, do the pathology, extract the DNA, and do the gene profiling, and then process and analyze, etc. That process now takes about 3 weeks. And it can be a little bit shorter, but not that much shorter. It may be able to go to 2 weeks. The 2 first weeks in those 5 weeks is about finding the patient and getting that other hospital organized so that they can ship the sample to a university hospital where they'll do the analysis. And that part is surprisingly slow sometimes. At the moment, we encourage clinicians to plan while their patient is on the last line of treatment in standard of care, so they register patients early for the National Molecular Tumor Board, get the diagnostics done a little bit ahead of time, you could say. But I think we will, when we get the logistics sorted with other hospitals, we will be able to get to 3 weeks at least. And then we rush some hematology samples we can rush through AML and other things.
So actually, I feel 5 weeks is a pretty nice timeline if you think of it from end to end. It's not just analysis, it's the whole process. So I guess that's a great achievement. There's a question from Christian Britschgi, my co-chair.
Yes, just a very practical follow-up question to that. Have I understood it correctly? You will discuss every case at the Molecular Tumor Board. And I guess the initiative will ramp up as this will become more known in the country also. How do you manage resource-wise, or how many cases are you discussing per week currently, and how will you manage in the future?
So at the moment, how we do this is that it's not fully scaled yet. So we need to deprioritize some samples. There's a sort of prioritization meeting every week for diagnostics. And if the patient, for example, if the patient has had a small molecular gene test before, so we know that it's a colorectal cancer with a KRAS mutation, we cannot offer anything, we deprioritize the patient, for example. And then we look to see that we have new referring clinicians. We always discuss them. Clinicians that referred samples several times. And if the answer is obvious and there's no benefit, they may be answered out directly. And then if it is the case where there are findings, we try to discuss those. And then we see that we've been able to go down and down on time, because it gets more and more effective as more people know more about how the interpretation goes. We see that we're down to 4 or 5 minutes per patient now, so we can cover 12, 13 patients in an hour or so, and the meeting's usually an hour. We think that when this is scaled fully for Norway, we'll be able to run something like 48 samples per week over 6 different sites. And that may cover the need, be about 2,500 per year. We think we will have to regionalize this and maybe also split it so that there are, hematology goes separately, etc. But we're not there yet. So at the moment, we sort of work together to see how we could build it. And there's a lot of sort of dissemination of knowledge, basically.
Okay, thanks again. So we are again running out of time. So perhaps I take the privilege to ask one last question. I wonder, do you have plans to move beyond genetic testing as well? So we've heard a lot about drug testing, circulating tumor cells. So any more plans to move in different directions?
So we're looking at flow-based tests for protein biomarkers, particularly for some hematology indications, some other protein biomarkers that will get sort of easily in, and then we're looking at drug screening. And we have some cancers where we're more advanced with the drug screening. So we're about to open the first cohorts in the IMPRESS trial that will use something other than genetics. Yeah, so I think that will be the next to happen.
Okay, so thanks again. That's a very impressive program. Thanks also to all the speakers for their talks. I guess we had a very instructive and fascinating afternoon with these different talks. So thanks for joining the 3rd Zurich Precision-Oncology Symposium. And I'm looking forward to see all of you at another meeting in the near future. Have a nice evening and goodbye to everybody.
Goodbye also from my side to everybody. I think 2 pieces of housekeeping information we need to convey. Silke Uflacker would be very pleased, and we as well, if you could give us feedback simply by scanning the QR code. And then if you need credit points, you may send an email to cccset@usz.ch, if I understood correctly.
The credits will be sent out to all registered participants.
Okay, automatically.
Automatically, yeah.
Perfect. And thank you very much to you, Silke, for perfect organization of this event.
Thank you, everyone, for speaking, and have a nice evening.
Thank
Bye-bye.
you.
Thank
Bye-bye.
Thank you. Bye-bye.
Good evening.
Good evening.